Ma'am, you can start now.
Yeah, thank you so much, Komal. It's an honor to invite all of you to this second online certificate course on endometriosis of the FOGSI Indian ICOG for 2023. And it's my honor to welcome the chairperson of ICOG, Dr. Lakshmi Shrikande, the vice chair, Dr. Parag Biniwale, the conveners, Dr. Ramani Devi and Dr. Asha Rao, the co-conveners, Dr. Abarani, Dr. Sneha Buer, and Dr. Reena Wani, all the esteemed faculty who are joining for today and for your precious time and giving your inputs for such a great topic, as well as all the delegates who are joining for this program. It's a great honor for us to welcome you all. Can we have the prayer song, Komal?
No sound.
Make it full screen.
There's no audio. We can't hear Komal.
I can see the
Nilima
sound
ma'am is
file
sharing,
has
ma'am.
crossed.
Nilima ma'am is sharing.
Okay, Nilima.
Yes, ma'am.
आवाज नहीं है.
Yeah.
It's okay. You stop. You stop sharing. Can stop sharing, Anil. Yeah, thank you. So this is the program which has been formulated by the conveners, Dr. Ramani Devi and Dr. Asha Rao. And it's my honor to now invite Dr. Lakshmi Shrikande, the chairperson of ICOG, to bless the program before we start. She's a founder, patron, and president of ISOPA Vidarbha Chatna and chairperson of the IMS Education Committee. I request Madam to say a few words before we start the program.
Yeah. Thank you so much, Chamila. As a ICOG chair, I'm really very happy and pleased to come out with this second online 3-day course, and this time it is FOGSI ICOG online course on endometriosis. And as you all know, Dr. Ramani is an expert, a master in endometriosis. So along with Dr. Ramani, Dr. Asha Rao, they both are conveners, and Charmila is our series convener for these online weekend courses. And I also welcome our co-conveners, all the speakers, experts, and chairpersons. Dr. Ramani will be telling you in detail how we have come out with this program and what is the need. But as Dr. Ramani will also tell you that sadly, even most of our FOGSI and ICOG members and fellows, they need to be sensitized and they need to be made aware about the endometriosis, the recent updates in the diagnosis, the management issues, and also how to spread awareness in the general community as well. So that was the basis, and that is how we have conceptualized this online course on endometriosis. And I welcome all the delegates for this online course. And I hand over back to Dr. Chamila for further proceedings.
Thank you so much, ma'am, for those blessings. Now I would like, it's an honor for me to introduce the conveners for the program. Dr. Ramani Devi is a past vice president of FOGSI, and she has won several awards. And as Dr. Lakshmi ma'am was saying, she's an authority on endometriosis, and it's an honor for us to have her convening this program. The other convener for the program is Dr. Asha Rao. She's presently the chairperson of the Endometriosis Committee of FOGSI. She's got an experience of almost 25 years in ART, and she also runs postdoctoral fellowship programs in reproductive medicine and gynecology. Welcome, Dr. Asha Rao, for your convening. We're extremely thankful to both of you. The co-conveners for this program are Dr. Abarani Sinha for the first day. She's a professor and HOD at Muzaffarpur, and she's also a ICOG Governing Council member at present, and she was a president of the Patna OBGYN Society. The next convener for tomorrow will be Dr. Sneha Buer. She was the chairperson of the breast committee of FOGSI in 2019 to 21, governing council member of ICOG at present, and she is the chairperson of the medical disorders committee of AMOGS. Welcome, Dr. Sneha. The third convener for the third day will be Dr. Reena Vani. She's a professor and head of department at R.N. Cooper Medical Hospital, Mumbai, and she's also the program committee chairman of AMC. Welcome, Dr. Reena. And I would like to say a few words before I request Dr. Ramani to talk about the preamble of this program. The attendance for all 3 days course is compulsory. You have to attend on all 3 days to get the certificate. A Google link for all the MCQs will be put up in the chat box. And people who have attended all 3 days course and pass with the 50% marks on each day, then only you will get the certificate from ICOG. So you have to attend for all the 3 days, pass with 50% the evaluation questions which are put up before we start the talks for the day, and the certificates will be sent within 1 month. Thank you so much for to all of you for joining. My request, Dr. Ramani Devi, to start the program by giving a preamble for the talks today.
Thank you, Dr. Charmila, for your kind introduction. First of all, let me thank the team ICOG, headed by Dr. Lakshmi Shrikante, for giving me this opportunity. I think the most needed topic that has to be discussed in the current day scenario is endometriosis. And all of you know that March is the awareness month for endometriosis. Probably we are a bit ahead. So we want to be ahead in everything, in right from the diagnosis to the management. See, around 196 women all over the India, all over the world suffer from endometriosis as per WHO. And according to the Endometriosis Society of India, it is around 40+ million women in India alone suffer from endometriosis. And they have two important things to be addressed. One is the chronic pelvic pain and infertility. And again, I tell you, the awareness about endometriosis, as Dr. Lakshmi said, among the doctors, among the consultants, unless they are tuned to this particular disease, it's quite, I should say, it is quite suboptimal. And as well as when you think about the patient, it is totally, they are zero. They know something about the PCOS, but hardly less than 5% of the women they know about endometriosis. So this is Endometriosis Awareness Month. I would request all the consultants to spread the message regarding endometriosis to your own public people. And then again, it's the time that we need to update our idea regarding endometriosis, because there is quite a lot of paradigm shift in the diagnosis, management, and follow-up of this patient. And the first thing is, we always say that gold standard in diagnosis still is supposed to be the laparoscopy, but now all the learned societies like ESHRE, ASRM, World Endometriosis Society, including FOGSI, we are supporting only just go by the diagnosis should be based on the symptoms, and you can start the medical management. The second thing is, once when we find endometriosis patient, the surgeons were itching. They wanted to do the surgery, but now that concept has quite changed, and we are for medical management currently. And only if the medical management fails, then we need to go for the surgical management. That too, we need to have a perfect training in that. Again, the management of infertility in endometriosis, as again, there is a paradigm shift. Originally, we thought diagnose, do surgery, then put suppressive therapy, then go for ART. But now it has totally changed. Once when you diagnose, and if the patient wants only fertility treatment, you move towards it. Maybe ART is going to be the first line of management. Then give her a baby, then followed by permanent suppressive therapy with medical management. Rarely, if you're going to do surgery, it should be the only one surgery, and it should be the ultimate. So with this concept, we thought we should create awareness regarding each and every segment of endometriosis, starting from epidemiology up to the what is the relationship between malignancy and endometriosis, how one patient once diagnosed with endometriosis should be followed lifelong, because we know that it is not a disease that is going to happen between menarche and menopause. Even it extends its wing beyond menopause, and likewise we do come across a lot of young adolescent girls. Once we thought that biomarkers are not going to be it's an only under research test setting. Now we know that biomarkers may be in near future It may be the one which is going to identify the diagnosis in a much earlier way and follow. So with this introduction, I feel it is each one gynecologist, we need to understand each and every aspect of endometriosis. So we have planned it. Me with Dr. Ashara had taken a lot of troubles to take 12 hours program and with all interactive sessions. And we have chosen excellent speakers, including some overseas speakers. So I think for the patient, for the consultants who are listening to this, participating in this, will have at the end of the program, will be having a good basic knowledge and even an advanced knowledge about endometriosis. With this, I think we can move on to the next thing, that is the pre-questionnaire.
Thank you so much, ma'am. Komal, please put the link now. May I request Dr.
Yes, ma'am.
Ashara to say a few words while the link is being put on? Please, ma'am.
No,
Thank you,
no, she
Sharmila.
will put a link when we are putting the timer. So let Asha speak and then we will tell Komal to share the link.
Okay.
Asha, please.
Yeah, dear friends, as a chairperson of endometriosis committee for last 4 years, our motto has been think endometriosis and fight endometriosis. And I thank profusely Dr. Lakshmi and the ICOG team for having helped us in putting up this fight and for helping us to compile this wonderful program. And she has so much enthusiasm, energy, and she has seen into every nitty-gritty point of it to make it a very successful seminar. And thank you, Dr. Lakshmi. And the disease, once again, everybody has emphasized that though it is 200 years old, we still have so much ignorance, confusion about the right ways of diagnosis and so many disputes in management. And I'm sure this meeting, this conference will help you to know a little more about this disease. Thank you.
Yeah. Thank you, ma'am. May I request Dr. Ramani Devi to take over, please? Now she can put the link from her.
Yeah.
Okay, ma'am.
Please share the link. So dear delegates who have logged in, you can see in your chat box the link for pre-test MCQs. So you have to just open the link. 10 minutes will be given to you. After 10 minutes, this link will become inactive. So Komal, once you share the link, you start the timer as well. Everyone has to see their chat box. Yeah, she has already shared the link. Start the timer, Komal. Yeah, she has started the timer as well. Yeah. Komal, Abarani madam को co-host बनाओ. हाँ.
Yes, ma'am.
Start sharing the questions.
Yeah. Everyone has to just click on the link and it is open. Very simple. They all can put their answers and submit. There are 30 questions and you all have been given 20 seconds to solve one MCQ.
There's only 1 more minute left. Thirty seconds.
Yeah, the time is up. Komal? Komal,
Yes, ma'am.
you can make the link inactive now.
Yes, ma'am. Yes, ma'am.
Ramni, let's start with our scientific session. And
Yes.
please don't worry, these are the similar same questions which will be asked to you in the post MCQs. So
That
this
is
is
going to
just
be
an
tough.
evaluation that before the start of course where you stand, and once you hear to all the experts, so how much you have gained from these experts. So the similar questions will be asked in the post MCQ. So be alert and attentive when the speakers are talking. Yes, Ramni.
Yeah, yes, I think Dr. Abarani has come. Komal, kindly you share the PPT.
Good evening.
Welcome, Philip.
Yeah. Hello.
Welcome
Good
to
afternoon.
India.
Welcome, Dr.
Hello.
Philip.
Thank you very much.
Welcome to India.
Thank you. Happy to be with you. Can you tell me at what time you want me to give my lecture?
Ramni, can you just calculate his time? So,
Yeah, just 1 second.
yeah, just a minute.
Thank you so much.
$5:20 to 5:30.
So I think after 1 hour, we can come back.
5:05 to 5:20.
So what time is it for you?
It's 5:05 to
Sir, it
5:20.
is the fourth topic for you, sir. So roughly it will be after 45 minutes. You can, your talk
Okay.
will be after 45 minutes.
Yeah.
So I
So
connect
you
with
join
you
after 40 minutes.
40 minutes.
I will message you, text you, sir.
So
Oh,
let
thank you
your
very much.
audio video be there. Philip, just mute your audio video and join us after 45 minutes. Yeah.
Okay, very good.
Yeah.
I'll be
Don't
there.
log out. Yeah.
Thank you so much.
Good evening, Ramni Devi Madam. Am I audible?
Yes.
Yeah, you are
very
very
much.
much.
So good
Very
evening,
much.
everyone. Dr. Lakshmi Shikhande Madam, Dr. Ramni Devi Madam. So here we are now for the scientific session of the FOGSI ICOG online certification course on endometriosis. And we move on with the first scientific session. And the chairpersons for this session are Dr. Basa Mukherjee, who has been the Vice President for 2021-22, and he has been also been the ICOG Governing Council member, and he has been with us as Vice President, Bengal Obstetrics and Gynaecological Society. The CV is not yet being displayed, but I think I can introduce Dr. Sneha Bhuyani. She is the ICOG Governing Council member.
That has already been introduced. Abba, Dr. Snega is already introduced.
Okay, madam. So may I now invite Dr. Basa Mukherjee to start the scientific session. The first speaker is Dr. Lakshmi Shikhande, who will be speaking on overview of endometriosis. So Dr. Basa Mukherjee, sir, please introduce Dr. Lakshmi and start the scientific proceedings.
Hi, Dr. Abha. I think Dr. Sneha will introduce.
Yes.
Dr. Sneha is my co-chair. We decided before that Dr. Sneha will do the honors.
So
Dr.
I think,
Sneha, you want to take it over?
just
Thank you so much, Dr. Basa.
in 2
Yes,
lines. Yes.
a very good afternoon, everyone. And it's my proud privilege to introduce Dr. Lakshmi Shikhande, who is the current ICOG chairperson. And as everyone knows, she's very vibrant, and she was the chairperson of HIV and AIDS committee, and she's a past vice president of FOGSI. We're very eager to listen to you, Dr. Lakshmi, and as all of us can know that we are almost having a daily masterclass and lots of activities with ICOG. So thank you so much. Over to you, Dr. Lakshmi, for
Thank
your
you.
lecture.
Thank you so much, Sneha, for your kind words. So friends, topic for my deliberation, as it is, I am the opening batsman, so it has to be nothing but the overview of endometriosis, because this is the basis for all the upcoming course talks and modules. So first and foremost, though it looks very basic, but let's start with the definition. Endometriosis is a benign disease where there is a presence of endometrial glands and stroma outside the endometrial cavity. And as Ramni has already said, it affects 7 to 10% of women and 3% of women of fertile age. Prevalence, it varies in each study depending upon the population surveyed, but in asymptomatic women, it varies from 0.7 to as high as 45%. 6 to 18% of women undergoing sterilization, they are prone for endometriosis, and 15 to 70% of women who experience chronic pelvic pain this pain might be because of endometriosis. So what is the prevalence in India? At least 26 million women of reproductive age are affected in India, and globally, this prevalence is 176 million. So you can see that the burden is huge on India as well as across the globe. Study by ESI in the year 2018 says that more than 33% of women in reproductive age group in India are affected by endometriosis. And as Dr. Ramni was saying, less than around 5% girls below 18, that is early adolescent girls who complains of dysmenorrhea, they might be suffering from endometriosis. So here is the need for sensitizing and spreading awareness about endometriosis amongst our own colleagues. So these are the two Indian studies. One was done by Dr. Vineet Mishra in 2015. And as you can see, another study is by Dr. Ramani herself, which she published in 2016. And both the studies, they are on incidence of endometriosis in the infertility population of India. And you can see that again, the endometriosis burden is huge, ranging from 34% from Dr. Ramni's study to 55% in Dr. Vineet Mishra's study. And they also studied the incidence of stage 1, 2, and stage 3 and 4 disease in this infertile population. So what are the theories when it comes to endometriosis? Friends, there are many. Still, we don't have a clear-cut theory of pathogenesis. It can be retrograde menstruation, metaplasia, hormones are also blamed, oxidative stress and inflammation, immune dysfunction, apoptosis suppression and alteration, genetics, and stem cells. So theories are many regarding the pathogenesis of endometriosis. Other causes apart from these can be Mullerian anomalies with or without obstruction. They can also lead to endometriosis, and endometriosis could be genetic in origin or because of DES exposure in utero. 0.8 to 12.5 billion euros are spent every year according to EndoCost study by World Endometriosis Research Foundation due to treatment, either medical or surgical, and loss of work. So you can understand the economic cost is also huge when it comes to endometriosis. Work, study, social, sexual relationships, all are affected, and they render the life of this woman very, very challenging and frustrating. Data from recent large case series have documented cumulative rate of recurrence, which is as high as 30 to 40% at the end of 2 to 3 years of follow-up. So what are the symptoms? Everyone has to remember the 7 Ds. And what are these 7 Ds? Dysmenorrhea, dyspareunia. It is dysmenorrhea, dyspareunia, dysuria, dysphagia, DUB. We no more call it DUB. It has to be AUB, but just to make life simple, you can remember DUB, diffuse abdominal pain, and difficulty in conception. So these are the 7 Ds which one has to be aware when you are seeing patient in your day-to-day OPD. The common symptoms, 13% they come to you with UTI symptoms, 14% come to you with dyspareunia, 6% comes to you with vaginal discharge. But as you can see, the majority of these women, that is 34% of these women, they come to you non-specific GI symptoms. There are 3 types of endometriosis: peritoneal, ovarian endometrioma, and deep endometriosis. Epidemiology, Dr. Ramni was already discussed. It can be because of early age of menarche, prolonged and profuse bleeding if she is having short cycle, can be because of constitutional factors. If she is having a family history of endometriosis, then she is 6.9 times more prone to have endometriosis. Smoking, I will come in my future slides. Smoking is a big culprit as far as endometriosis is concerned, and the role of alcohol, caffeine also I will discuss in my further slides. Late marriage and childbearing, they are having association with endometriosis. As far as socioeconomic status is concerned, it is found to be more prevalent in higher socioeconomic status. It is a hormone dependent condition. So like fibroids, adenomyosis, they are more prone to develop endometriosis. In utero exposure to DS, dioxin, patients who gives you history of spontaneous or induced abortion, and this can be because of immunological factors as well. So if your patient is giving you history of any immunological disorder like SLE, thyroid disorders, rheumatoid arthritis, you can be aware and alert as far as endometriosis is concerned. What is the association between neonatal uterine bleeding and risk of endometriosis? The presence of neonatal uterine bleeding may represent a warning sign of the future development of endometriosis, and it increases the awareness of devastating disease in the young woman. Neonatal uterine bleeding is also associated with maternal PIH and low birth weight, and there is also association of this neonatal uterine bleeding with ABO and RH incompatibility, as RH women, negative women are found to be more prone for endometriosis. This is a very interesting study where the authors have studied the school absenteeism in the adolescent girls. And what these authors concluded is of vital importance for each and every delegate who have logged in for this course. They have concluded that the rates of dysmenorrhea and school absenteeism caused by dysmenorrhea are high. According to recent studies, these patients are at higher risk of development of endometriosis. Whereas the knowledge of the disease is of course low among the adolescents who are investigated, so also the knowledge is low amongst the health professionals who are managing these adolescent girls, and the knowledge of endometriosis is also low amongst the counselors who are counseling these adolescent girls. So everyone, the girls, the women, the healthcare providers, the counselors, there is a need to educate them about endometriosis and its symptoms to reduce the significant lag of time which happens between the symptoms and the diagnosis. And that is the whole purpose why we all are here for this 3-day course on endometriosis, because once you have diagnosed it correctly, naturally you know how to manage it. So what is the role of menstrual factors? Women with early menarche are at higher risk. Lifelong heavy bleeding and short cycles, again she is at high risk. Dysmenorrhea we have already discussed, as this dysmenorrhea fits in with the retrograde spill theory of Sampson. Now, detoxification enzyme glutathione as transferase has also been made responsible, and family history, as I was saying, it is if your sister or identical twins or your mother is suffering from endometriosis, if first degree relative of women affected with endometriosis, they have 3 to 9 times higher risk than controls. 6.9-fold higher increase among family members, and future research has to be focused on this genetic basis. It needs to be evaluated. There are possible association with dermatological conditions like pigmentary traits or sun habits. Presence of red hair, freckles, and sensitivity to sun exposure are associated with endometriosis. Also, association between light eye color and endometriosis has also been observed. What about the link between BMI and endometriosis? This association seems to be conflicting, as risk of endometriosis is found to be lower in obese individuals, maybe because they have oligoamenorrhea and reduced flow. Women with reduced waist-hip ratio and reduced waist-thigh ratio, they have a higher risk of endometriosis. Recent study has shown that girls who are overweight at 16 years of age have high risk of endometriosis later in life. Available data regarding smoking and endometriosis are limited and controversial, but smoking impairs estradiol and progesterone synthesis, and hence it reduces the risk of endometriosis, but smoking can trigger pro-inflammatory gene expression. So there is no harm in reducing the intake of smoking if a woman comes to you with endometriosis. Same goes with alcohol, as moderate intake of alcohol, that is 100 ml, may increase estrogen levels due to increased aromatase expression. It interacts with LH, leading to increased production of estrogen, and alcohol on long-term use affects immune function, and it regulates production of pro-inflammatory cytokines. Remember, there is a significant association between alcohol intake and chronic inflammatory disease. What about caffeine? The caffeine permitted per day is up to 7 grams per day. Caffeine affects hepatic production of SHBG and it reduces bioavailable testosterone. It also inhibits aromatase. Recent studies proved that there is no association between caffeine and endometriosis. What is the role between diet and endometriosis? Again, it is controversial. Fats, they increase the incidence as it increases the estrogen level. Dairy products, beef and red meat increases the incidence, whereas omega-3 fatty acids, vegetables rich in vitamin C, carotenoids, folic acid and lycopenes and micronutrients, they decrease the risk of cell proliferation and hence indirectly the risk of endometriosis. Nulliparity with prolonged and profuse bleeding are definitely at high risk of endometriosis. Parity is inversely related to the occurrence of endometriosis. Risk of endometriosis reduces with increasing parity, suggesting the protective effect of pregnancy due to high progestin levels. As far as socioeconomic status is concerned, I have already told you that it is more prevalent in higher socioeconomic status in educational and occupational levels. The site of endometriosis, it has been found that it is more common on the left side as compared to the right side. And why so? Because endometrioma, diaphragmatic endometriosis, ureteric endometriosis, they are common in left side, and this could be due to the presence of sigmoid colon and the deposits are not exposed to the peritoneal current. Other factors which can contribute to this side disposition is lymphatics, blood flow, and local growth factors which promotes left side dominance. Again, use of oral contraceptives, the conflicting results are seen. What is the association between dioxin? The studies in 1990 proved exposure to dioxin may be a cause for endometriosis. GI symptoms, as I was saying, 34% of these women, they come to you with GI complaints like bloating, abdominal pain, constipation, diarrhea, nausea, vomiting, and irritable bowel syndrome. Endometriosis is also associated with autoimmune disorders like rheumatoid arthritis, SLE, psoriasis, thyroid dysfunction, and multiple sclerosis. Association with non-Hodgkin lymphoma is also suggested. It has been also correlated with the patients who are having asthma and allergy. So all these links could suggest that endometriosis has immunological mechanism as well. Is there any relationship between endometriosis and malignancy? We all know it's a benign condition. It has features suggestive of malignancy like development of local and distant foci, invasiveness to the peritoneum, and damage to the target organs. It causes morbidity, but not morbid mortality like malignancy. In the last decade, on epidemiological and biological studies, endometriosis has been associated with a definite increase in risk of various malignancies. A risk between melanoma and endometriosis has been reported. Endometriosis is also associated with higher prevalence of endometrioid carcinoma of ovary. Is there any link with our cardiovascular system and endometriosis? Yes, women with endometriosis, they have 1.4 to 1.6 times higher incidence of myocardial infarction, coronary artery disease based on the findings of nurses' health study 2. Probably this may be due to elevated inflammatory factors, oxidative stress markers, high levels of LDL lipoproteins in these women of endometriosis. So to conclude, the retrograde spill of the endometrium is considered to be the main factor for the origin of endometriosis. Ovulation is also considered to the major determinant of the onset, which is available on the basis of data by the use of combined oral contraceptive pills. Future studies should verify if the actual manifestation of endometriosis are partly due to dramatic modifications in modern women's reproductive habits. Future epidemiological investigations should also focus on risk factors that are biologically plausible, are preventable, and they have high impact on the population. So friends, this was all about the overview of endometriosis. Thank you for your patient hearing. If you are having any questions, we will take it at the end of the session 1.
Thank you so much, Dr. Lakshmi, for that wonderful, much needed overview about endometriosis. As you have rightly pointed out, it's not only the common public, but it's the healthcare workers and health professionals as well. We need to have the high index of suspicion. We ourselves need to be aware of this disease, and that's the reason we need to have awareness amongst the healthcare workers as well. Catch them early and treat them at the right time. I think that's a message for and on this, especially the awareness month of endometriosis. I think with this, we can go ahead and back to you, the MSc. Thank you so much.
Thank you, Sneha. We move on. And the next talk, we want to hear from Dr. Sampath Kumari. Dr. Sampath Kumari is well known to this crowd. She's a champion of adolescent health. She's very passionate about adolescent health during her chairpersonship and before that. Now she is the vice president of FOGSI. She's a very supreme active lady who also inspires a lot of academia and a lot of social awareness to people around her. I'm glad that she's here as a part of this module. And Dr. Sampath Kumari, it's always a pleasure to see you, hear you, and be with you at different social causes. And here we want to hear from you on adolescent endometriosis. Thank you for being here.
Dr. Bhaskar. First of all, I thank Dr. Lakshmi Madam and Dr. Ramani Madam for giving me a wonderful opportunity. Dr. Bhaskar, we had a wonderful time in AICOG. Fantastic time. We can never forget it. Yes. Now, as he told, my favorite topic is adolescent. Today we will see about the topic given to me is adolescent endometriosis. As all of us know, this adolescent is a period of transition from childhood to adulthood. So this is the period by WHO from 10 to 19 years is considered as adolescent. And during the early adolescence, we have the development of secondary sexual characters. And the middle adolescence being the identity from parents attracted by the opposite sex. And the late adolescence is the well-formed opinion and idea. So we cannot never neglect the adolescence and we cannot support everything the adolescents do. It's our duty to streamline the adolescence. So the girls, as far as the girls are concerned, whenever I go to the schools for adolescent counseling, I used to talk about the menstrual hygiene and the menstrual history. The girls should know what is happening in their body. So what this HPO axis, hypothalamus, pituitary to ovarian axis, as all of us know, this HPO axis should, every girl should know about the HPO axis, how the bleeding occurs from the genital tract, and the first bleeding occurs to the genital tract is the menarche. Now this 18-year-old girl complains of pain during menstruation, periodic bloating, constipation and diarrhea, and she has attained menarche at 14 years. How we are going to proceed? See, this dysmenorrhea, as Lakshmi Madam was telling, there are many students who take leave on every first and second day of the menstruation every month. So this dysmenorrhea, as all of us know, this can be a primary or secondary. Primary refers to the recurrent crampy lower abdominal pain that occurs during menstruation in the absence of pelvic pathology. It can radiate to the suprapelvic or inner thigh, accompanied by the vomiting and the headache and the nausea. Then comes the second, congestive dysmenorrhea. It is a painful menstruation in the presence of pelvic pathology. That is the dull, aching lower abdominal pain due to pelvic congestion. In that becomes the endometriosis. Mainly the fibroid with the adolescents are very bad. So when the girl complains of dysmenorrhea, we have to categorize it whether it is a primary, and we cannot tell always that it is normal. You take this diet and water and it will go on. It's endometriosis. Now the incidence with adolescents is increasing and it has to be ruled out. Usually we used to tell the triple dysmenorrhea, that is pain during menstruation, before menstruation and after menstruation. This Lakshmi Madam has already told in detail about the endometriosis. This is a common benign and gynecological disorder resulting to the presence of endometrial glands and stoma outside their normal location. So here we can see this endometriosis. Endometriosis affects 6 to 10% of the women of reproductive age, and almost 40% of infertility cases are mainly with the endometriosis. The exact prevalence with the adolescents, it is very difficult to diagnose because we are not going to decide. The laparoscopy, though it can be the golden standard to diagnose the endometriosis, we are not for laparoscopy in the adolescents. So approximately 60% of the adult women with endometriosis experience symptoms before the age of 20. They may not be knowing, but they would have started in the earlier stage itself. So this theory, I think Madam has given a wonderful idea, and finally the retrograde menstruations, that is the main part. As all of us we know, Sampson's theory, Mayer, coelomic metaplasia, Albin's theory, which is the extrapelvic endometrial cells, and theory of immunity. So as these are all the theories which is with the endometriosis, but still we don't know which is the common cause of the endometriosis, where genetic. Now our Ramani Madam is doing the PhD in the endometriosis also with the RH, micro-RH. So this retrograde menstruation, lymphatic and vascular dissemination of endometrial cells and the coelomic metaplasia is supposed to be think of the cause for the endometriosis. As she told, a Mullerian anomaly nowadays can lead to increased retrograde menstruation and having shown to increase the risk of endometriosis in adolescents. So the symptoms, as we know, the stages, it can be a minimal, mild, moderate, severe. I think this is depending on whether it is superficial or deep, depending on that, the treatment will vary. So what are all the symptoms normally with the girls? Acyclic or cyclical pain. 63% of the girls will have the cyclical pain, and acyclical pain only in 28%. Cyclical pain being in the 69%, that is totally. Gastrointestinal pain. Many times the girls will come and tell, during this time I have the constipation, during this time I have the diarrhea. This is associated with 34%. And sometimes they may also have the pain during the 6 weeks. Madam was telling dysuria. Those urinary symptoms were present in 13%, and irregular menses being 9%, and vaginal discharge 6%. These are all the common symptoms with the adolescent girls. The localizations of the ovary, that is ovarian endometrioma, is rare before 25 years. Now we have even the endometrioma. This severity of pain, this girls always should have the diary of the maintenance. That is about the menstrual calendar, when they are getting the bleeding and when they have the pain, whether the pain is severe during or before or after menstruation, and documenting the severity of pain, whether they are taking any tablets, and this pain is related to the bowel and bladder habits, whether they are going to the school or getting themselves absent from the school. These are all the things which is needed. This calendar, if it is needed, it will be easier for us to meet for the intervention. If she is always getting absent from the school, means at least we have to start with the medical management. Now, how are we going to diagnose in the adolescents? Mainly with the ultrasonography. We always go with the abdominal ultrasound in the adolescents. With the 3D and the 4D Doppler, it can be easily diagnosed, and the differential adnexal pathology, if anything present, can also be diagnosed. CT has only the limited role. For this case of endometriosis, in the doubtful cases, MRI can be done. CA125 is very sensitive but not specific. So the serum CA125 is needed. So do not use this to diagnose endometriosis. but it coincidentally its value is increased, raised the serum CA 125. Maybe coincidence that it means that the girl may have the endometriosis. There are other lot of biomarkers to diagnose endometriosis. That is the interleukin 6, 8, and the tumor necrosis factor, the cancer antigens being CA19 and 9. These are all the things they are not doing, but these are all the latest biomarkers with newer urocortisone, 88% positive in endometriosis, 90% specificity, and the polystatin. These are all the newer biomarkers which can be used for the diagnosis of the endometriosis. As far as the ultrasound, it is done by everyone. It can be this endometriosis, it can be unilateral or bilateral, and it can be having the kissing ovaries, unilocular or multilocular. The septa may be thin or thick, and the mobility always when we examine it is restricted, and the mural echogenic foci will be present. Low level internal echoes with the posterior acoustic enhancement called ground glass appearance. The nodular wall thickening. These are all the features when we think to suspect of endometriosis in a adolescent girl. When there is a suspicion and if you are very doubtful, in that cases you can go with the MRI. That MRI should not be used as a primary investigation. Pelvic MRI to assess the extent of deep endometriosis involving the bowel, bladder, or the ureter. This pelvic MRI are interpreted by a good profession. That is, they should be expert with reading this MRI. So endometriosis in adolescents. That is what will be the picture with the laparoscopy is typically clear and red and can be difficult to identify it earlier. The adult endometriotic lesions will be, as all of us know, it is a powder burn lesion. Whereas this here it is a clear and red lesion. Why we want to diagnose the endometriosis in adolescents and why we want to treat it? This is mainly to control the symptoms. Mainly they have the dysmenorrhea. So this pain has to be corrected and prevent the disease progression from the adolescent. If you are not identifying and corrected, in future they will end up with the case of infertility. As I told you, 40% of infertility mainly with the endometriosis and the fertility issue. So these are all the three things, the reasons which has to be identified in the adolescent and it has to be treated. Control of symptoms, prevention of disease progression, and the fertility issues. What are all the treatments we are going to do? As such, suddenly we are not going to go for an surgical procedure as far as the adolescent is concerned. Medical management should be the first diagnosis. That is the non-hormonal therapy. It can be a hormonal therapy, and later, if it is not controlling and the patient is having severe pain and the patient wants to get relieved of the symptoms, in that case, you can go for the surgical excision and destruction of any visual evidence of the endometriosis. What are all the non-hormonal management we are doing? As usual for dysmenorrhea, we used to give this NSAID, that is the mefenamic acid, the brufen or naproxen. This can be given, and this, for the endometriosis, it may be less effective, but to certain extent, the pain can be get relieved. And the side effects may be gastritis, and we can add over the kind of, if you want, she can have some antacids also. What are all the hormonal treatments? If they are not comfortable with the pain, then we have to go with the hormone. As far as the girls are concerned, it is better to go with the progesterone combination. That is the norepinephrine. Progesterone can be given alone, or progesterone with the combinations of the estrogen, nauseous can also be given. But most of the time, it is better to go only with the progesterone. This progesterone, as all of us know, the anti-endometriotic effect by causing initial desensitization of the endometrial tissue followed by the atrophy. So the medroxyprogesterone may be given, that is the 50 milligram per day, or depending on that, the dose can be 10 to 20 milligram per day. As usual, the side effect is very minimal, there's a nausea and vomiting only. Nowadays, the progesterone for the girls, previously we thought that if the progesterones are given by injection, that may be the bone mineral density will be reduced. But there are a lot of studies which tell that even the injections can be given to the adolescent girls, the DMPA, that is, they are comfortable with the injections and the bone mineral density is not at all disturbed, this also, it's not reduced. The dinosol, as we thought earlier, nowadays it is not used. Now we have a lot of newer agents which is useful for the adolescents also. This Dynogest, this is a wonderful drug which is used for the endometriosis, that can be given for the adolescents. We have a lot of studies, Diana studies and lack of studies which tells that the Dynogest 2 milligram per day decreases the endometriosis associated by pelvic pain. By week 4, the score decreased to 36 points. By one study, as per the week of both, the endometrial thickness has been reduced. So the Dynogest 2 milligram milligram per day, I think it can be given for 6 to 9 months, which will reduce the pain, and it is also useful for future effects. And these are all about how the progestin acts. Already I have told it is the reducing the serum estrogen level, immunomodulatory effect, it has an anti-inflammatory effect, and the desmyelinization and atrophy of the endometrial tissue, inhibition of matrix, and they have the anti-angiogenic effect. So the progesterone is the main drug which will be useful for the adolescent. As I told, the diagnosis can be used for this adolescent. This GnRH, sometimes this can also be used, but main thing is this, the patient may not have the bleeding. So if they don't have the bleeding, again, the pain will not be there. With endometriosis, who have pain, refractory to conservative surgical therapy and suppressive hormonal therapy, often benefit from at least 6 months of the GnRH agonist therapy. For time being, it can be given with the add-back therapy, and the non-steroidal anti-inflammatory drugs can also be given. So the diagnostic laparoscopy should be the last identification. So diagnose, and if at all needed during the diagnosis itself, we can go with the management. As I told, the inspection, the typical lesions will be red, clear, or white, as opposed to the powder burn, which can be present in the adults. Expect all lesions on the rest of the anatomy. That is, the fertility preservation is very, very important. These are all the guidelines which says that medical management, which is the first line, preferably progesterone, and the GnRH being the second line of management. The Mullerian anomaly, finally, it is one of the cause for the endometriosis, and most studies show that 5 to 6% to 40% of the Mullerian anomalies are also present. The clinical outcome in patients with outflow tract obstruction differ from those with such obstructions. So this is only one case study which the college student, she don't want to get for any surgery management. At present, current fertility is not a problem, and she don't want to get leave from the school. She strongly desires the pain has to be relieved. What is to be done for this girl? Only pain has to be relieved in this girl. In this girl, progesterone was started, and after that she was given GnRH also 3 weeks later, and one dose, and after 28 days, another dose was given. Up to 12 months, this GnRH and progesterone was given. The patient was comfortable, and she finished her course, and she joined that whatever future she joined some company for her work, and after that only she got married. So we have to think, it is a patient choice is also very, very important, whether to go for surgical management or the medical management. So this lifestyle is very important, diet and exercise, and omega-3 fatty acids, caffeine, this and all, Lakshmi Madam has told everything in detail, and the yoga, dancing, the lifestyle is the main important for the adolescents for all problems, PCOS, endometriosis. So the take-home message is coping with endometriosis. It is a chronic disease, is an important component of management. The pain relief with the NSAIDs or the hormonal treatment. Now the dialysis being the best drug, and laparoscopy, if the endometrioma is more than 5 centimeters in an adolescent, if needed, we can go for laparoscopy. Psychological support is very, very important, and follow-up is important. The multidisciplinary approach is always helpful to improve the quality of their life. Thank you once again. I thank the Lakshmi Madam and Ramani Madam and the entire team for giving me an opportunity. Thank you, Madam.
Thank you, Dr. Sampath Kumari. Thank you very much for highlighting very important things in the adolescent, mainly the atypical symptoms, the presumptive diagnosis of medical treatment, which we often do for a long period of time. So thank you, Dr. Sampath. I think they will be having some discussions later, time permits, after this session is over. And for the next speaker, who's none other than Dr. Kuldeep Jain, may I ask my co-chair, Dr. Sneha, to kindly invite him and introduce him.
Kuldeep Jain, is he there?
Yeah, Dr. Kuldeep is very much logged in.
Okay,
Yeah.
That's fine.
Sneha, are you muted? I think she's having network issues. Basar?
Yeah, I can take over.
Yeah.
So, so Dr. Kuldeep is a renowned sonologist in Delhi, and he has multiple publications and multiple academia to his credit. He has been a part of FOGSI in the past, and Dr. Kuldeep today will be taking on the imaging part of endometriosis, if I'm correct. That is what we want to hear from him. Dr. Kuldeep, the floor is yours. We are all eagerly waiting to hear from you.
Thank you, Dr. Basa. I'll just make a correction. I am a gynecologist. I am not a sonologist. So thanks for your kind introduction.
Yeah. Gynecologist specialized in imaging. I think that should have been the right one. Sorry.
I've been doing infertility, imaging, endoscopy, embryology,
Everything. Thank you. Thank you, Dr. Kuldeep, for the correction.
Thank you
Please
so
go
much
ahead.
for your kind introduction. Yeah.
Yes, sorry for the disturbance. I got disconnected meanwhile.
Yes,
please go ahead, Dr. Sneha. If you want to introduce Dr. Kuldeep properly, then please go ahead. Mine was
he's
not
already
correct.
introduced. Let Kuldeep
Thank you.
start.
Thank you very
Sneha
much.
can continue. Sneha can continue.
I think, yeah. Sir, everyone knows, sir. So I think we can go ahead. We can cut short the introduction. So over to you, sir.
Yes, already finished.
Thank you, and thank you having me here, Dr. Lakshmi, Dr. Asha, Dr. Ramni, and this is a wonderful program for teaching. So I am very happy to be part of it. Today I am going to speak on imaging dilemmas in endometriosis and adenomyosis. We all know that endometriosis is a multifocal complex disease, and whenever we speak of endometriosis or adenomyosis for that matter, because both are sister disease, they go hand in hand in more than 30% of the cases. When we talk of diagnosis, management, as well as the follow-up, it has always been in debate and controversies, and that is because it is involving multiple organs. It is not only limited to pelvis, but there are extra pelvic organs also, like lung, scar, cervix, and anywhere in the body you can find endometriosis. That's why the presentation is also different. Very important thing in diagnosis is you have to have a suspicion of endometriosis depending on the symptoms, and then you can continue your effort on diagnosis. I will be restricting to the imaging part of the diagnosis because that is the topic which I can cover in the next 15 minutes. So let us see what are the options. We are having non-invasive options and invasive options. When we talk of non-invasive, ultrasound is the primary modality to diagnose endometriosis. We can use grayscale, 2D, and if need be, you can use 3D, but ultrasound remains a primary modality. Transrectal ultrasound is again a very highly sensitive tool in our hand, especially for deep infiltrative rectal nodules, and then we can add color to enhance our diagnosis. But ultrasound is having limitations. It is having very poor sensitivity if there is no endometrioma. So if endometrioma is there, the sensitivity is very, very high. But in those cases where only small disease is there is no endometrioma, very early endometriosis, ultrasound may not be very helpful. Another modality is MRI, and this is very good for deep infiltrative pelvic nodules. So whenever there is a doubt in your patient, that patient is having a deep infiltrative pelvic nodule, the sensitivity is quite high, like 90% sensitivity and very high specificity, that is 91%. And for subperitoneal implant, it is quite helpful. There are other modalities by which you can diagnose, that is invasive. Laparoscopy remains gold standard and may be the only tool in some cases. It helps you in classification and it gives a therapeutic advantage, so you can treat the disease at the same time. But there are again limitations. Deep disease may be missed because of adhesions. So when you put the scope, you have to be very, very careful to look into each and every corner of the pelvis to find out the deep disease. And of course, confirmatory diagnosis is always histopathology, but again, histopathology may not be very helpful in many of the cases, especially the old scarred endometriosis. What are the diagnostic dilemma? Usually it starts at adolescent age. Dr. Sampath has already highlighted the problem of diagnosing adolescent endometriosis. Usually it starts in adolescent and only symptoms could be the severe pain. And when the patient gets married, don't conceive, then they usually present it. And problem is early disease cannot be picked up by imaging. Like I already told you, if there is no endometrioma, that sensitivity becomes very, very poor. And especially in adolescent patient where you cannot do the transvaginal scan. A trans-abdominal scan is having very poor sensitivity to diagnose endometriosis. And confirmatory diagnosis is always by invasive laparoscopy. Most women becomes accustomed to painful. So painful menstruation at early age is not taken as a endometriosis. One should have a doubt if the adolescent girl is missing a lot of schools, especially that is very, very important. In one of the study, that was the only criteria taken to diagnose endometriosis and which was confirmed on laparoscopy. Given the extensive endometriosis, it is not possible to have, it is possible to have minimal symptoms or they may not be having any symptoms. And presentation is very variable, there is considerable overlap. And many times physicians have few diagnostic usually invasive. Now, we know that there is a collection of old blood, and that leads to the formation of pseudocysts in ovarian endometriosis, leading to the adherent to surrounding structures, and that leads to distortion of anatomy. So you have to keep all these facts in mind when you are putting these patients for the diagnosis. And definitive diagnosis certainly is based on endometrial tissue and hemosiderin latent macrophages in the biopsy. For ovarian endometriosis, TBS is less operator dependent. It is very useful for diagnosis of endometrioma, having a sensitivity of 83% and specificity of 98%. So when you are having endometrioma, TBS becomes the tool of choice, and this is level A evidence. The GDG recommends that clinicians should base their diagnosis of ovarian endometrioma on the basis of recently published ultrasound characteristics of ovarian endometrioma. These are some of the assay recommendations. Clinicians should base their diagnosis on the basis of ground glass ecogenicity, and that is because of the collection of old blood which gives you the picture, and one of the 4 compartment, and there should not be any papillary structure with detectable blood flow. It is again a level A evidence. You can see here, this is the classical picture of endometrioma. The cyst is filled with low internal egos, and there is a acoustic enhancement the posterior side. So once you find this type of picture, the diagnosis is 100% certain that this patient is having endometriosis. It could be a single cyst or multiple cysts could be there. But here you can see they are all separate and there is no septa as such. So when you are having septa running into the cyst, you should keep other diagnosis in your mind. Now, when the patient is with infertility, it is not only looking at the endometrioma, that patient is having endometrioma. There are other things which you need to see at the same time. One is ovarian reserve. We know that endometriosis causes decrease in ovarian reserve, and there is repeated cyclic hemorrhage within a deep implant, which replaces the ovarian tissue. So you have to look for ovarian reserve in these patients. Then there are peritoneal to ovarian relation disturbed, one will find para-ovarian adhesions that leads to LUF. So one needs to see the para-ovarian area. There will be loculated para-ovarian collection in most of the cases. Then when you are doing follicular monitoring, it is difficult, and accessibility is again difficult during pickup. And one may find hydrosalpinx in severe cases of endometriosis. So it is not only the endometrioma per se, but these are the things which one should look in these cases. Now, what are the differential diagnoses? You have to keep age and size into consideration. A unilateral complex cyst may be a endometrioma, it could be cystic teratoma, it could be hemorrhagic corpus luteal cyst, or a follicular cyst or serous tumor. So when you find this type of picture, it is looking like ground glass, but there is a hyperechoic nodule here, and these hyperechoic nodules usually suggestive of dermoid rather than endometrioma. So one has to be very careful when looking only at the ground glass and avoiding discarding this hyperechoic nodule. Then there is the corpus luteum cyst, which is very common change during the menstrual cycle. And if you are not keeping in mind the menstrual cycle day when you are scanning, then you may be over diagnosing the endometrioma. And how to differentiate between two, you can see in corpus luteum there is a fresh hemorrhage and there is mesh-like appearance. It is not ground glass opacity, and depending on the time of the hemorrhage, you will find this type of level. So that is typical of corpus luteum rather than endometrioma. Then there will be multilocular mucinous cyst adenomas. There you will see multiple septae. Multiple septae in a cyst, usually serous cyst adenomas, not endometrioma. And then there is a follicular cyst, which keeps on changing its diameter as the menstrual cycle advances. So you have to follow these patients to confirm your diagnosis, in which phase you are doing the ultrasound is very important. And when it persists over the period, then the diagnosis of endometrioma becomes more common. Then hydrosalpinges. You will find hydrosalpinges, incomplete septae within the cyst, usually suggestive of hydrosalpinges. The shape will be different, and there will be reticular pattern or fibrin strands can be there. What about the transrectal ultrasound? This is a very important and sensitive modality for diagnosing, especially deep rectovaginal nodule. It is very highly sensitive, specific for rectal endometriosis. You can see it may be superior to MRI. It is actually rarely used, but underused modality. One should promote the use of TRUS, especially in young girls and in those patients where you are suspecting deep rectovaginal nodule. It is 97% sensitive modality. However, there is poor acceptance and one has to counsel the patient. What about MRI? Should it be done in all cases? No. I think primary modality remains the transvaginal sonography, but in those cases where you are dealing with adolescent and early disease, you may find MRI useful. When you are having atypical or doubtful adnexal mass, again MRI will be more sensitive than transabdominal or transvaginal sonography. If you are suspecting malignancy, then again MRI becomes the modality of choice. And when you are suspecting deep infiltration nodules in rectovaginal space, it is having a very high sensitivity and high specificity. Now, what you can see in MRI, large field of view, multiplanar capability, contrast resolution is there, and very high sensitivity to 90% for endometrioma. Now, mapping of deep infiltrated endometrial lesion is very important before you proceed for resection, and there MRI really helps. Extensive pelvic adhesions where you cannot see the even during the laparoscopy, there MRI imaging is very helpful. For endometrioma, the sensitivity of MRI is 97%, but for endometriotic implants, when there is no endometrioma, again it is having a poor sensitivity. So it should be used in selective cases, especially where there are laparoscopic blind spots and rectosigmoid involvement. This is classical picture. You can see the obliteration. There is fibrotic endometriosis and cul-de-sac is obliterated. What are the limitations of MRI? Non-pigmented lesion will not be hyperintense on T1. The small foci may have variable signal intensity. Plaques like implants are difficult to delineate. Adhesions cannot be directly identified. We have to rely on distortion of normal anatomy. And peristalsis, gases, and fecal residue may mask contours. These are some of the limitations of MRI. A word about adenomyosis, because endometriosis is usually associated with adenomyosis in more than 30-35% of the cases. It is again difficult to diagnose and difficult to treat. In lack of homogeneity architecture, most productive heterotrophic endometrium is seen as a hyperplasia, reactive hyperplasia, which is hypoechoic, and echogenicity depends on ratio of endometrium to fluid. So these are some of the pictures where you can just find out. You can see the myometrial cyst. Endometrial junction is poorly delineated. There is globular uterine enlargement. It obscures endometrial and myometrial border, especially on the posterior side. There is pseudo widening of endometrium. You can see here there is pseudo widening of endometrium because of the increase in the junctional thickness, and it is more seen on the ventral rather than dorsal endometrium. Then you can see the inner myometrium is hypoechoic and heterogeneous, and usually the presence of myometrial cyst. Again, cyst in inner myometrium you can see here also, and then echogenic linear striations are seen, and they are very diagnostic. Like this, you can see the adenomyosis. Color Doppler again help in differentiating adenomyoma versus leiomyoma. Vessels are located at the periphery of the lesion. There is low PI goes in favor of low PI and RI goes in favor of leiomyoma, and high PI and high RI goes in favor of adenomyosis. So you can see here, this is adenomyosis and this is myoma. This becomes important when you are an operating surgeon. If you are not very sure of your diagnosis and you have not mapped, then you may be in trouble when you are operating. Thickening of junctional zone is very diagnostic, like this. If it is more than 12 mm in MRI, it is suggestive of adenomyosis. Then this is picture of pseudo widening of endometrium, very classical picture of diffuse adenomyoma. So when we talk of diagnosing imaging modality in endometriosis and adenomyosis, ultrasound and MR imaging corresponds to the varied appearance of this disease at histopathologic analysis. Endovaginal ultrasound initial imaging modality is endometriosis for adenomyosis as well as for rectal endometriosis. And MRI should be reserved for cases which are in doubt or when you are suspecting a malignancy, and in those cases where you cannot find a endometrioma. Thank you very much for your patient hearing.
Yes.
If there are any questions, I will be happy to take on. Thank you very much.
Thank you. Thank you so much, Kuldeep sir, for that excellent presentation. Very well said that yes, imaging is a very important or helpful non-invasive diagnostic tool for endometriosis. And yes, you have very rightly pointed out, yes, transrectal ultrasound is very, very helpful as far as the unmarried and especially the adolescent girls are concerned. MRI is very good, but yes, for adolescent and atypical presentation, especially when you want to rule out malignancy and you want to map the deep infiltrating lesions. So the message very well delivered, sir. Thank you so much. And over to you, Dr. Basar, for further.
Thank you.
Dr. Kuldeep, thank you, Dr. Sneha. And Dr. Ramani, do we have Dr. Philip? Has he joined again?
Yeah. He's here.
Hi, Hi, Dr. Philip. Nice to see you. And do we have an introductory slide? Dr. Philip is a Vice President of FIGO. He's a very well sought after international speaker. And one of his work, which he has been speaking of in different forums, is the salivary test for endometriosis. We were always privileged to hear him at the AICOG. I recently posted a picture of him, Dr. Jeannie Conry, and Dr. Ravi Chandran together enjoying at the AICOG on Facebook recently. And we all have had the privilege of hearing him before. So this is Dr. Philip. This is Dr. Ramani Devi's ICOG certificate course on endometriosis.
Not mine. It's FOGSI certificate course. I'm only the convener.
Yeah. Okay, Lakshmi, you can welcome Dr. Philip and I think.
Yeah, welcome Dr. Philip. This is FOGSI ICOG online certificate course on endometriosis, where we are having a 12-hour module. And every day we are having 4 hours allocated to this course. And all the delegates, they have to give pre-test and post-test on both the days. And those who pass on all the 3 days and they attend on all the 3 days, only they are eligible for this certificate. So this is the certificate course of FOGSI ICOG. And we welcome you to this course as our esteemed international faculty.
Thank you. Thank you very much. I'm very happy to be here with you today. I'm going to share my screen. And of course, it's a great honor for me to speak in front of so many people for this course. Okay, here we are. So, okay. Okay, I'm sorry. Perfect. Can you see the screen? Is it okay?
Yes, sir. Yes.
Perfect.
So I would like to introduce my lecture saying that it's a perfect combination with Dr. Koldis Jain, the previous speaker. And finally, I'm following what he said, and it was a very good lecture because we have a big problem with endometriosis, as it's been said before, and for the diagnosis. So I've been lucky enough to have been involved in a research project with several French centers to deal with the salivary microRNA tests for the diagnosis of endometriosis. So I'm going to try to explain you this, how it works and what we did. Okay, so I go through this slide. It has been said in the first lecture. We all know the prevalence of endometriosis and how annoying it is for all those women. I was impressed by the numbers of women in India. Of course, you have such a big country in the first slides that were shown by the first speaker. So there's a delayed diagnosis, and the average time to diagnosis, it's been said before, is 7 years. And for 40% of patients, it's more than 10 consultations, and it's been written in the literature that women see 3.3 gynecologists before arriving to the diagnosis, and also 25% will go through laparoscopy. So it's a major problem for our society. It's a major problem for the women at first, of course, but also for the society. There's been a very good paper in the New England Journal of Medicine in 2022, a review article saying that a delayed diagnosis is difficult for the patient. And again, it was in this paper 7 to 10 years. Okay, so what does it mean? It means for the patients wandering, suffering, many investigations, and of course, discrepancy. So where do we come from for the diagnosis? First of all, the questionnaires. There was a beautiful meta-analysis published by Eric Surrey from California in 2017. And the conclusion was, well, if we go through all the literature, there's no diagnostic test, there's no questionnaire that can give us the diagnosis. There were two French papers, not because they're French, but very interesting. One from Arnaud Fauconnier, one from my good friend Charles Chaperon, trying to find a better questionnaire. But the conclusion is it's not enough for all patients and for the majority of patients. So when you go through the ESHRE guidelines published 1 year ago, exactly 1 year ago, it's written that there was no evidence that the questionnaires can reduce the time to diagnosis. This is Charles Chaperon's paper, very good, but it's not enough for all patients, although interesting for a good number of patients, but not enough for all patients. So this has been said before. When we look at the literature, you see that the performance value of each test is different, but it's not enough. You see the medical questionnaire, we've been talking about this. Ultrasound imaging, it has been said before, MRI imaging, blood test not good, and even surgery, because you know that you can have a microscopic disease, and even when you do a biopsy, you can be not in the right place and you can miss the diagnosis. So what I'm going to show you through this lecture is that the saliva test has better sensitivity and fantastic specificity of 100%. So going through the ESHRE algorithm, it's written that we have, of course, to perform a clinical examination and go through imaging, and this won't change with the test. This is very important. You need to have an ultrasound and so in some cases an MRI. And the ESHRE experts wrote that there was no biomarkers, and this is normal because again, the ESHRE guidelines were published 1 year ago, and our work was published in 2022. Interestingly enough is the recommendation about MRI and surgery. You see that it's written, and we all know this in everyday's life, that a normal MRI does not mean that you don't have a diagnosis, because you can have a superficial peritoneal disease. And also they write that, as I said before, a negative laparoscopy and even a negative histology does not entirely rule out the disease. So it's a complicated problem, and this is where the test will be interesting. So how does it work? We've been interested since a few years by those RNAs. You know that the COVID vaccine came from the messenger RNA, which is another story, but you also know that this vaccine was elaborated by Moderna in 42 days. And why was it possible to elaborate such a complicated vaccine and to save so many lives? Because they used what is called NGS, new generation sequencing, and artificial intelligence. And this is what we did for this work. We are gynecologists. We started with 3 teams in France, and now we have 15 teams in France. And also we will launch an international study with Indian colleagues who are here today. So how does it work? Why did we came to this? We understood through the literature that the microRNAs are blocking the translation between the messenger RNA and the protein, and this is involved in the endometriosis pathogenesis. So this is the first paper published 7 years ago, explaining the role of the microRNAs. And we now know that those microRNAs interfere and have a role in the pathogenesis of endometriosis. So the early paper, sorry, it's in French, came from a Chinese team. It was exactly 10 years ago, and they worked on this, and they said, oh no, it's not good, we cannot draw a conclusion, but they didn't use NGS and artificial intelligence. So the first serious, I would say, paper came 5 years ago by Kavita Panir, and she pulled out a few microRNAs, and she started thinking that they could be involved in the mechanism of pathophysiology of endometriosis. The second important paper came from Sarah Mustafa in 2020, published in the American Journal. And again, you see there were 5 microRNAs involved, but of course this was not enough to have a diagnostic signature. So then a few case reports. You see, there was a meta-analysis 2 years ago in 2021 in the Einstein Journal. A few microRNAs were picked in the literature in several studies, but again, not enough. You see the name of those microRNAs. So what did we do? We've been working with this company startup who were experts in NGS and artificial intelligence, and we wrote a protocol, and we started sending them blood samples of patients who had endometriosis, who had a laparoscopy to be 100% sure of the diagnosis. And finally, I'm always saying this, that the work is coming from the engineers, not from the doctors, because they put all this information, and of course they have millions of data with NGS and artificial intelligence. And the good point and the fantastic result is that, and we published this 1 year ago, exactly in February 2022 in Diagnosis, they pulled off 2,600 biomarkers, 2,600 microRNAs. Remember the first papers, 5, 6, 7 microRNAs. And then with this technique, they could give us a result with 2,600. And what are the results? This is the paper which was published. We have 86 biomarkers who are different, 86 microRNAs were different among patients who have endometriosis. So you see you have a very high sensitivity, 96.7, and a specificity of 100%, and accuracy rate at 98%. So it's really very interesting and really amazing. And this was the first step. So we had another paper published to study the bioinformatics approach, studying the microRNA with NGS, very interesting too. And after this, while we were performing the first study, launching the first study, we read this article in the Einstein Journal, and they started saying, why don't we look at the saliva for those microRNAs? And we said, wow, why? Of course, interesting, very interesting. So apart from the blood, we launched the blood study where we were already thinking to the saliva. And so we launched another study with saliva with more than 200 patients. And this is the paper. If you want to read only one paper on this topic, read this one in the Journal of Clinical Medicine 1 year ago. And it's very interesting because we had a control population and, of course, patients with endometriosis. And you see that the control patients were exactly similar to patients with endometriosis. And very important point, 100% of each group had dysmenorrhea, of course. And so the results are 109 biomarkers different. You remember 86 in the blood, and more, it's even more accurate in the saliva, and 109 biomarkers with a sensitivity again of 96.7 and specificity 100%. So it's even more accurate in the saliva. So very exciting results. So we published another paper showing that saliva is better than blood. Of course, it's better because it's easier to collect. It's non-invasive. You don't need a nurse. You can have a patient who is far away in the countryside, and she will give the saliva. I will show you how it works, and send it to the lab. And it's very safe and very stable. And we did several studies with the same sampling, having a study after 1 week, 2 weeks, 3 weeks, 4 weeks, and the results are exactly the same. So it's very stable. And the last paper we published was about infertility patients. And this is, to my opinion, a very, very important and very interesting field. We are starting to work on this too. So in this population of 143 patients diagnosed with endometriosis, 24 were infertile. And among those 24, we pulled out 34 microRNAs, which were linked to endometriosis-associated infertility. So everyone can understand how important it could be to have a diagnosis of endometriosis among infertile patients. One point, very important point, is the concept of artificial intelligence and sample size, because we are clearly entering a new world with this artificial intelligence, and the way of thinking has to be different. So because we had many questions at the beginning saying, okay, you only have 200 patients, that's not enough, you need 1,000, 10,000, whatever. And there's a literature about this. And what we have to understand is, you see this paper was published 10 years ago, but there are many since. And what we have to understand is that artificial intelligence is, the computer is making an analysis of many millions of criteria. So when you shake this, when you compare this, you don't need such a huge number of patients, and it's written that from 150 to 200, it's enough, and you got results that you can use and that you can believe in. And you see the predictive positive value in random forest is of course different. And again, from 150, it's enough. So that's very important, because the answer to the question, are you sure that your population is big enough to give those results? But of course, we didn't stop there. We published last year 7 papers, and we are ongoing on different studies. And the biggest studies is what we call the 1,000 study, which we've been launching among 15 centers in France, as I said before. And we finished this study right before Christmas, and we are now working on the results and writing the paper. But in between, we wrote an interim analysis manuscript, which has been submitted, and we are waiting for the answer of the reviewers. And the good news is, for this interim analysis with external validation, the results are exactly the same. So we are very optimistic about this. So back to Eshrey organigram. What is the indication of this test, finally? First of all, it's not a screening test, it's a diagnosis test. Very important. It's not for all the young girls who have dysmenorrhea, and it has to be prescribed by a doctor, and the results have to be given by a doctor. It's very important. So you have your patient in front of you, you're doing, as before, clinical examination, ultrasound, plus MRI if you think it's necessary. And you see on the right side of the slide, you've got an answer. You've got endometrioma, you've got deep infiltrating endometriosis. So no interest for the test. It's medical, surgical treatment, whatever, what you're doing now, no change. But the important point, the interesting thing is when you have a normal ultrasound, and so you can go directly on the left part of the slide, you can go directly to the endo test saying, okay, the ultrasound is normal. We're going to check, or you can give a treatment to place your patient in amenorrhea if she was not before, and if it's efficacious, then you stop, no test. If it's not, there is a place for endo test, because this is, to my opinion, the group of patients which is dedicated to this test, because you will avoid some laparoscopies, because we all know that after this, the next step is to perform a laparoscopy to check what is inside the body, even if the MRI is normal. And we all know that 50% of those laparoscopies are normal. So it's very important. And we have also another problem in Europe, maybe not in India, but more and more patients don't want to have hormonal treatments. And they say, no, I don't want it. I don't want a pill. I don't want this. So it can be an answer saying, okay, it's here. We don't start an empirical treatment. We don't start an hormonal treatment. We go directly to the test and we'll have the answer. So again, it's not for all the patients. When I saw the millions of women in India, not all those millions of women will benefit from this test. So in conclusion, I want to say that it's a very exciting project, as it's been said before. The salivary test is a non-invasive diagnostic test with a high accuracy, specificity, and sensitivity rate. Of course, as I said before, it's very interesting because of an easy sampling, non-invasive, you don't need a nurse, you don't need a doctor, it's safe and stable. And so the idea is to decrease the medical wandering, and of course, decrease the burden for healthcare system. So again, it's a diagnosis test. It's not a screening test. And as I said 3 slides before, the interim results of the external validation confirm the relevance of the test. And again, we are waiting for the reviewers. This test is available in Europe. It's been launched in Switzerland in October, in Germany in December, and it should be available in 10 European countries in the first semester of 2023. So before June, in the next month. We don't have the test in France, curiously, because it came from France, but the startup is French also. The medical team is French, but the startup is French, because we are discussing with the government for the reimbursement, and we are quite optimistic on this topic. So you understand that there are many next steps. First of all, we are waiting for the results of the 1000 study, which again has been completed before Christmas, and we'd like to have an answer concerning the phenotypes. One could imagine that you have more than 100 microRNAs in the saliva. You could say from 1 to 20 it's peritoneal, from 20 to 40 it's bladder, endometriosis, and so on. So we'll see the results, but it's very exciting. We of course want to launch a teenager study. We want to launch a big fertility study and the one for adenomyosis, because adenomyosis patients were not in those previous studies. And as I said before, after my lecture in Calcutta with FIGO, I had several contacts with several of you who are here today, and we will launch an international study, and we'll be very happy if we can collaborate with Indian experts like you. So these are the papers. Just to draw your attention, I'm nearly done, Mr. Chairman, just to draw your attention on the fact that it's not only in gynecology, it's not only for endometriosis. I call this the microRNA revolution, because if you go on Google search or Cochrane, you see a bunch of or PubMed, sorry, not Cochrane, PubMed, you see a bunch of papers in all fields of medicine. You see pediatric multiple sclerosis, pulmonary arterial hypertension, gastric cancer, and in oncology, you have many papers. And there's even a paper talking about potential therapeutic molecule in cancer with microRNA. So maybe the next step will be not only a diagnosis, but a treatment, but we can dream. We'll see, but it's really very exciting, and I'm very happy to be part of this team and this project. So this is how it works. The patient receives a box. You see on the left part of the screen, she's giving the saliva here. She shakes and puts the tube in an envelope and send it to the lab. It's very easy. Don't need a nurse, don't need nothing. Every patient can do this. We had the prizes in France because it's such an advancement. We had a Therapeutic Advancement of the Year award, which is very important in France in May. And more than this, we had the prize of the Academy of Surgery, French Academy of Surgery, and the Prix Galien, which is a huge honor, of course, which was given more than 1 month ago in December 2023 in Paris. So here we are. And of course, I want to advertise FIGO meeting. As a FIGO VP, you know that FIGO will be held, the World Meeting will be held in Paris in October from 9 to 12. And of course, we hope to meet you there and to have a strong Indian delegation. Thank you very much for your attention. Thank you so much.
Thank you, Dr. Phillips. It's wonderful to hear from you. And on this new test, I'm sure that it's a lot of people who haven't heard you before also be interested. There are people who've heard you before and they would keep the interest is still on. We are waiting for it to be available in India. But before that, of course, the study, as you rightly said, I think that's something which a lot of people would be looking forward to. Dr. Lakshmi from ICOG would love to lead it from here. I think we run out of time. Dr. Lakshmi, do we have time for discussion? If you can. Paris, I think in FIGO, you will have the largest Indian delegation. There's no doubt about that. You will have people, I think there'll be more people from India than they'll have people from France out there. Yeah.
Oh, yes. Oh, yeah, of course. We have much more gynecologists. Yes, of course. You're such a big country.
Dr. Lakshmi, with your permission, just few words.
Yeah,
Phillips, that was very nice. Again, listening to your lecture. And we thank you for accepting our Indian colleagues to be a part of your research project. And as you know very well that I have been into this particular miRNA, but not in saliva, but in the serum of patients. And we are getting excellent results. And the sensitivity and the specificity is too good. It is my study. It is similar to Dr. Phillips' study. And we'll be happy to be a part of your research project. Thank you for accepting our invitation and being a part of this wonderful. Thank you.
Thank you. And I'm waiting.
What is the cost of this test? What is the cost of this test, Dr. Asha?
Yeah, so now the cost is 700 euros. You have to know that there's a technology behind this. And all the tests which are sold in the United States, for example, are sold between 700 and 1,500 because technology is quite huge behind. So it's according to other countries, it's 700 to 800. But of course, you know, when the test will be worldwide, I think the price will get lower, of course, as always, you know.
Sir, in India, we are getting it done for 13,000 rupees. 13,000.
So how much is
Same
it?
5 miRNAs, what you have mentioned, we are getting it done for 13,000. Probably because of
$150, around $150.
Yes, yes.
Interesting. Okay. We'll talk about this, of course.
Yeah,
Very
later. Ramni,
So-
I can't see any questions which are posted.
But,
There are
I
no
think-
questions posted in the chat box, Dr. Lakshmi.
Yeah, if there are any questions, you can
So
take it.
there are appreciation messages for all the speakers. They have really done well. And but there are no questions, Dr. Lakshmi.
Yeah, so I think me and Ramni would like to emphasize one thing again and again, that if any woman comes with chronic pelvic pain, please don't label it as a psychosomatic disorder. And when any early adolescent age group girl comes to you with pain and dysmenorrhea, please don't label it as a case of examination stress or a malingerer or something like that. She's making up the study, don't want to go to school or something like that. As such, I understand when it comes to chronic pelvic pain, we don't get that much facilities and attention from the doctors also. And nobody tries to find out the reason behind this chronic pelvic pain or dysmenorrhea. So please don't label them loosely as of not any importance. Do think and remember endometriosis whenever these girls and women come to you with dysmenorrhea and chronic pelvic pain. Yeah, Ramni, if I missed anything.
Yeah, Dr.
you can
Reena
add
Mani
on to
wants
it.
to, Reena Mani has risen her hand.
I
Yeah.
have a question for our esteemed speakers. Wonderful talks, and the important message that we need not go ahead with surgical treatment.
Yes.
But I have personally had a lot of young girls who go with Dynogest. But there's a question: what is the maximum time we can continue medical management with Dynogest safely? Because this is a question which comes up very often. And
Yeah,
how
let-
is it in comparison with GnRH analog, and what do you prefer? I would like to ask.
Let me answer this question, Reena. See, like young girls lesser than 16 years, we are not supposed to use GnRH. But beyond that, we can have. But you know, the side effects of GnRH is going to be much more than Dynogest. So Dynogest, that was the Visan study, was one of the trials, pioneering trials, where they said that this Dynogest can be used for adolescent girls. And the study was only for 1 year, and then they. But currently there are studies which say we can continuously use Dynogest even for a period of beyond 5 years. As long as the patient is comfortable, continue to use this. And Dr. Soni Singh from Canada, actually, I was having a meet with him. He said for few of his patients, he has used it even for a period of more than 9 years till they wanted to get married. And my longest usage of Dynogest for my adolescent girl is beyond 4 years. And now we have coming out with another study of Dynogest in Indian population. That is the VISA study is ongoing. It's a multicentric trial where we want to target at least 200 women. So there is no harm in continuing to use Dynogest. Then one more point regarding Mullerian anomalies, because we see a lot of these adolescent girls with Mullerian anomalies and endometriosis. One advantage is when you see an obstructive Mullerian anomaly in an adolescent girl, surgery is the first treatment. Because when you're going to correct the obstruction, she's going to get relieved of the symptoms, as well as there will be definite regression of the endometriotic part. And you must also remember that this endometriosis, not in all cases it is going to be progressive. It will be progressive only in 30%, 30%. It will regress, and in 30% it will be static. So don't be in a stage in a early endometriosis, don't get apprehensive. You can counsel the patient, start them on medical management. And currently, if you are going to use oral contraceptive pills, according to Professor Chapran and Versalini, they say it is going to aggravate your symptoms, or it is going to suppress only the DIE, which the girl might get after once when she stops the oral contraceptive pill. So the ideal way to use is only a progesterone, probably Dynogest, or the next line is medroxyprogesterone acetate. So 30 milligram tablet is available currently. Plus you have a DMPA injection. That is what Sampath had already mentioned. That is available at free of cost in the medical, in the government institutions. So this can be the choice. But whatever it is, patient, young girls presenting with any symptom, you have to think about endometriosis.
Yes.
That is the message.
Thank you, Dr. Ramani. And a follow-up to this question. Now that the price control has come on the combination of Dynogest with ethinyl estradiol, instead of the regular combined pill, we have shifted from, because Dynogest by itself is costly. So I'm finding that it is a very good option, especially when the patient cannot afford, to give the combination of Dynogest with ethinyl estradiol because of the price capping has come. So I think, this is something which a lot of us practicing gynecologists can use, even when you are working with relatively poor patients. And of course, what you said was absolutely right, that if there's an obstructive anomaly, we do go for surgeries. But in fact, I would say even in a hospital setting, I have a lot of young doctors and medical students who are just delaying their marriage and childbearing, who come with ultrasound or other reports of endometriosis. And they are also very happy to continue medical line of treatment for a long time. So I think this is, I'm so glad you all have focused on this important topic. Thank you.
Reena, just one point, Dr. Asharaf here. There are papers about this combination of Dynogest with ethinyl estradiol, that the regression of lesions was not good with this combination, whereas it is very good with Dynogest alone. This is something that you have to think of.
Versilini has given a clear paper on this. Versilini's paper is
cost attractive, I agree with you, but then what is the future and what is the recurrence rate is what we have to think of.
Yes, thank you for that clarification.
Not end up one more surgery.
And suppose you start on medical therapy in an adolescent and her pain goes off. Can you stop, start?
No. You have to, once having started the drug, better to continue. Because once you are going to stop it, the disease is going to come back again. Because the symptoms are going to persist, then that means the disease is progressive. Probably in 30 to 40% of the cases. So please do not stop the drug.
And would you evaluate the endometrium in between, because it's known to cause a benign hyperplasia in some type of patient? And
no, Dynogest doesn't cause any benign hyperplasia. It causes desudolization of both utopic and ectopic endometrium. So there is no question of hyperplasia.
So what will be the problem when you use it for a long time without stopping, like 10 years, suppose she's not getting married?
Because longer study, it has come out and it has beautifully reduced the size of the endometrioma and the pain factor. So nothing happens, but maybe sometimes the patient can have breakthrough bleeding. That is one major concern. Maybe at that time, if the patient is beyond 16 years, we can combine with GnRH analogs. That might also help.
Ramani, let us go with the management session. I think many questions will be answered in that session. So let's start with session 2.
Section 2.
Thank you, Dr. Lakshmi. We sign out. Thank you, Dr. Lakshmi.
Thank you, Dr. Lakshmi. Thank you, Ramani ma'am, Dr. Asharaf.
Thank you. Thank you all.
Bye, Philip.
Thank you very much. Bye-bye. See you soon.
Bye, sir.
Bye.
Thank you, sir. Thank you.
Thank you very much.
And
Bye-bye.
all the speakers, Dr. Basab, the chairpersons, Dr. Basab and Dr. Sneha, and the speakers for this wonderful session, Dr. Sampath Kumari Madam, Dr. Phillips, Dr. Kuldeep Jain. Thank you so much for this wonderful, and of course, our Lakshmi Madam for the overview. And now we move on to the next session. And in our next session, we have Dr. Bharti Maheshwari as the chairperson. I hope she has logged in.
Yeah, she's here.
So Dr. Bharti Maheshwari, she is professor and HOD at Muzaffarnagar Medical College. She is an ICOG Governing Council member, a very active FOGSian, and she has been the past chair of MTP committee. So welcome, Dr. Bharti. And the other chairperson is myself. I have been already introduced. So straight away, we move on to the scientific session. Dr. Bharti, would you like to introduce the first speaker? Dr. Pratik Tambe?
Yeah. It is really honor to introduce Dr. Pratik Tambe. We all know that how good academician he is. And we are going to have a very good topic, and that is the how to changing trends in medical management of endometriosis. And we all have just listened the discussion on this. And we will have some further good things by Dr. Pratik Tambe, sir. So, Dr. Pratik Tambe, please
Okay.
So we all know about Dr. Pratik Tambe. So, sir, just on the topic, changing paradigm in the medical management. Yes, sir.
So let me begin by thanking Dr. Lakshmi Srikhande and the conveners of this course, Dr. Ramani Devi and Dr. Asha Rao, for including me to this prestigious ICOG course on endometriosis. As is usual, I will be speaking on the changing paradigm in the medical management. I hope I am audible and visible.
Yes.
Just doing a check because
Yes.
we are out of the pandemic, so we are a little less used to Zoom now. If you want something new, you have to stop doing something old. And that is what I'll be focusing on over the next 10 to 15 minutes in my talk. So I've structured this presentation in the following way. First, we start by talking about the goals of therapy. Then we talk about the treatment choices that are available to us today, the merits and the demerits of each of them. We debate the old versus the new and whether the new is really better than the old. And finally, we conclude with a management algorithm. There will be some overlap between my talk and those of the previous speakers. Of course, the elephant in the room is the ESHRE guideline on endometriosis, which was updated and published in 2022. The vast majority of my talk comes from here. There are also a couple of other sources which I will be quoting. One of these is the American Society for Reproductive Medicine's Practice Committee, which gave its opinion on endometriosis and infertility. This is the other one. And the third is Endometriosis Vision, which I was one of the co-authors and we released in 2019. It was a FOGSI publication. So let's start by asking the very obvious question. What are the goals for any medical therapy that we have to offer our patient? These will vary as per the severity of the disease. Obviously, somebody who has minimal or mild endometriosis, the goals of treatment are going to be vastly different from a patient who has stage 3 or stage 4, which is severe disease. You are more worried about pain, chronic pelvic pain, and recurrence in the later stages, whereas in the stage 1 and 2, you are more concerned with keeping the disease limited as far as possible. So obviously the goals of our therapy are going to be to control pain, to alleviate the symptoms of the patient, to improve fertility where that is a concern, especially when it's diagnosed in the childbearing age group, to enhance the quality of life, and finally to prevent recurrence of the disease, which is something we all struggle with. What are the various options that are available when we talk about medical treatment? Now, what ESHRE says is that based on what is the presenting complaint, and the most common presenting complaint that you will have is, of course, pain. You have the option of NSAIDs, you have hormone treatments which you can offer, and finally surgery. But at the end of the day, we need to take into consideration individual preferences, the side effects of the various medications that we prescribe, the efficacy, and finally the cost burden to the patient. And that's something which we've just seen being discussed extensively over the past 1 hour and also in the discussion which followed the speakers of the first session. So what are the pharmacotherapy options that we have? You have the good old combined hormonal contraceptives or COCs, which can be administered orally, vaginally, or transdermally. You can use them continuously. In fact, it is highly recommended that you use them continuously, and patients shouldn't have withdrawal bleeds in between, as we've just seen. You can use progestogens. These can be oral, like the progesterone only pill. You can have LNG IUS, which works very well. The etonorgestrel implant or Norplant also is supposedly one of the options that we can offer our patients. Personally, I don't have much experience with it, but it seems to work quite well, except for the bothersome and troublesome issue of breakthrough bleeding, which happens now and then. GnRH agonists we've been using since donkey's ages, especially as a endoscopic surgeon who specialized in advanced laparoscopic surgery. We've seen tons of patients who benefited from GnRH agonists, and we'll be debating their merits and demerits in just a few minutes from now. GnRH antagonist as second-line treatment is mentioned in the ESHRE guideline. I don't think many of us have used them extensively in our practice. Aromatase inhibitors is one of the class of drugs which has been described in our books. Again, we don't have all that much experience with it, and it's probably recommended as a third line of treatment and for patients who are refractory to medical and surgical treatment. So specifically, what do the guidelines recommend as far as medical management is concerned? When it comes to NSAIDs, yes, there is a weak recommendation that women may be offered NSAIDs either alone or in combination with other treatments to reduce endometriosis associated pain. As far as hormone therapies are concerned, it's a very strong recommendation that women should be offered combined hormonal contraceptives, COCs, progestogens, GnRH agonists or antagonists as one of the options to reduce endometriosis associated pain, because the entire pathophysiology depends on the entire guidelines say about combined hormonal contraceptives. It is recommended to prescribe women COCs. It's a strong recommendation as far as reduction of pain is concerned, also for dyspareunia, dysmenorrhea, and non-menstrual pain. This can be, as we said earlier, oral, vaginal ring, or even transdermal. So what does the guideline say about progestogens? And that's the vast bulk of this talk. There's a very strong recommendation that progestogen should be prescribed for women for EAPP or endometriosis associated pelvic pain. The LNG IOS is something which is strongly recommended as well. And if you read the guideline in detail, there's also one point where they recommend this for adolescents. And this is not something which we would widely use in India because of cultural reasons, but it seems to work very well in that population. Should we use GnRH agonists? Now, this is something which we've used left, right, and center, as we said earlier, but this is something which the guideline says should be reserved as a second line treatment only if hormonal contraceptives or progestogens are ineffective because of their side effect profile. We know that GnRH agonists cause bone loss, and therefore these are not to be recommended in the adolescent age group. Sandwich therapy is something which 15-20 years ago, as a surgeon, I have used very widely, following in Dr. Jack Dooney's steps. What does the modern guidelines say? It's not recommended to prescribe sandwich therapy, specifically the preoperative component of GnRH agonists, and this is a strong recommendation. But the post-operative medical therapies are very highly recommended, and they may be used to reduce the incidence of pain and, of course, to reduce the incidence of recurrence if a woman does not desire fertility immediately post-operative. Specifically for adolescents, I think we've covered this a little while earlier, that progestogens are recommended systemically or via an LNG IUS. You can also use these with limited benefit in certain other groups as well. How has Dynogest revolutionized treatment? This will be the vast bulk of the talk for the remaining 5 minutes that are left with me. And as you can see, Dynogest has selective 19 nor and progesterone activity. 2 milligrams per day is what is recommended. And when it comes to efficacy, on this table, you will see that there are only two options which have high efficacy as far as pain relief is concerned and prevention of recurrence is concerned: GnRH agonists and Dynogest. GnRH agonists unfortunately cannot be used for longer than 3 to 6 cycles. They come with their own basket of side effects, hot flushes, bone loss, and most of the patients after 3 to 6 cycles will probably say that doc suggests something else. When it comes to efficacy of Dynogest, when you look at all the various studies which are published, look at dyspareunia, diffuse pelvic pain, dysmenorrhea, and premenstrual pain, all of them decrease significantly by 90 to 95% within a very short period of anywhere between 18 to 24 weeks. This is directly taken from the Endometriosis Vision publication. Many of you who are present here were there during those meetings as well, and you have access to the original monograph as well. How long can we safely administer medical treatment? This is one of the questions that Dr. Reenavani and Dr. Ramani Devi were debating just now. And you will see here that most patients are absolutely fine when they take it for even up to 60 months. The side effect profile is excellent, compliance is very good, and the pain scores are significantly suppressed even 60 months into the treatment. When it comes to recurrence and you compare all the different options that are available to us, especially now that we are diagnosing endometriosis more and more in a younger age group, the duration of therapy and the efficacy of treatment both are of paramount importance for us as clinicians. When you look at no treatment being offered, you can have recurrence up to
Dr. Prateek, you're not audible.
His net is weak.
Perhaps he is lost.
Yeah, he is lost. Yeah, he has come back again. Yeah.
Yeah.
You have to unmute yourself, Prateek.
Prateek, unmute.
Prateek, please unmute and share your screen. I think for 1 minute, last 1 minute, we were not able to hear you.
Yeah. And Ramni, we will be taking questions at the end of the session too.
Okay.
Yeah.
Apologies, poor network. I'm sharing my screen again. Visible?
Yes.
Okay, so we'll go back to how long we can safely administer medical treatment, and you will see that this has been debated quite extensively. I'm just going to skip through these slides. You can give it for up to 60 months. As I was saying a little while earlier, you can have up to 60 months of therapy, which is validated by data from Japan, where they have the largest experience with Dynogest as a molecule. If you compare the different options that are available to us, the one which stands out the greatest
It's again gone.
I think again, we are not able to hear him.
agonist better than progestogens, and this is from the FOGSI GCPR, which Dr. Ramni Devi came out with.
Dr. Prateek, I think again, we had lost you for, I think, 1 or 2 minutes.
Today the network is really troubling me.
I think you can just
Summarize
switch
whatever it
video
is.
and then speak, I think. So you switch off your
Yeah,
video.
so I'm just going to finish. There are last couple of slides which are left, and I'm going to finish. How do we follow up these women? You have something called as a modified Stellenbosch quality of life score, which looks at 6 different key areas. This is our management algorithm. Again, this is something which is public domain, easily available. So I'll close by saying that medical management is quite effective. We have a variety of choices which are available. Progestogens, notably Dynogest, have significantly changed our practice over the past 5 to 7 years. They are much more preferred over GnRH agonists today. Long-term therapy is safe, effective, and prevents recurrence. But the key today, I feel, is that we need to have early identification, counseling, and recommend fertility preservation. Thank you very much for a patient hearing, and apologies for the poor network.
Thank you. Thank you so much, Dr. Prateek. So we now move on to the next speaker. I think we'll have the questions at the end of this session.
Yes.
So now we have the next speaker. She is Professor Hepzibah Kirupamani. She has been the past president of Obstetrics and Gynaecological Societies of South India. She is the president of Indian Menopause, past Indian Menopause Society Education Committee chairperson, and she has got a lot of, she's an accomplished academician with a lot of awards, and she has, I think this, I found this interesting that she has formed an app for midlife. She has got a patent model for episiotomy, and she has authored many books. So welcome, Dr. Hepzibah, and we are all eager to hear from you about endometriosis in perimenopausal women. So the stage is yours. Dr. Hepzibah, please. Is she there, Dr. Hepzibah?
Yeah, I can see
She
her.
must be there. Yeah.
Please unmute.
Yeah, she is there. She's there. Okay.
Able to see my screen?
Yeah. See your slide, madam. We can see.
Okay.
Go ahead.
At the outset, I thank the organizer. A special word of thanks to Dr. Lakshmi, Dr. Ramani Devi for bringing me here to share my few thoughts about perimenopause endometriosis. When the question given to me, few questions came to my mind. What is its incidence? What is its pathology? What is its clinical presentation? What are the diagnostic modalities available? And what are the treatment goals? And what are the risks of malignant transformation? So as we heard from Dr. Ramani, that today the 50 million women belong to India alone is suffering from endometriosis. And rightly pointed out by the American Society of Reproductive Medicine, the endometriosis should be viewed as a chronic inflammatory disease that requires a lifelong management plan with the goal of maximizing the use of medical treatment and avoiding repeated surgical procedures. So the endometriosis is not a problem of slowly reproductive years. And we always misunderstood the endometriosis. That is, it is always, it will resolve after hysterectomy, pregnancy, or menopause, but it is not always the case. So endometriosis should regress. That's what. But now our thought process has changed. There is a paradigm shift in our thought process. The endometrium should regress in the parallel with the regression of gonadal steroidogenesis during the menopausal transition seems like presumption. It is our presumption, but it is not exactly. And the elevation of symptoms also has not been shown to decrease in a longitudinal studies. So it has been the first reported case. It has taken 250 years to report. I think Dr. Ramani has mentioned about it. So just to know what is perimenopausal period, according to WHO and NAMS, it is the period 2 to 8 years preceding the menopause and lasts up to 1 year after menopausal last menstruation. So when we look at the perimenopausal symptom and endometriosis, it's really a challenge for the attending doctor and to the patient. And when we look at the incidence, it varies. In a study with WHO, it varies from 16.7 in perimenopausal, and in postmenopausal endometriosis is 4.2. Another study says 12 in 10,000. And when they studied 16,969 patients admitted, 40% of them is over the age of 40 years. So it varies from around 12% to 40 years. Coming to the pathology, it's actually, when we talk about pathology, it is incurable disease. And more so, it is complex because we do not know whether it's a continuation of previous disease or it develops de novo. So the probable explanation given for this is it can be a metaplasia or induction of endometriotic implants through continued gonadal steroidogenesis, or it can be due to exogenous estrogen, and it can be due to peripheral aromatization by adipose tissue and in situ aromatization within cycle of estrogen stimulating cyclooxygen activity, and prostaglandin might stimulate aromatization. So the clinical manifestation in perimenopause, it invariably can be a pelvic pain or a mass, but it mostly depends upon the location of the endometriotic lesion. Sometime in postmenopausal endometriosis,
We can see cutaneous manifestation in rare location also, and they have reported even hepatic endometriosis. So how do we diagnose? As already mentioned, it is based on, like any other disease, we have to take a detailed history because the pain and other symptoms is related to the location also. So it's based on history, the symptom, signs, and corroborated with physical examination, plus imaging techniques can be added. It's an adjunct to us. But finally, we have to prove with histological examination. We are doing some study on endometriosis. They insist on histopathological report. So the diagnosis of perimenopause endometriosis is the combination of laparoscope and histological verification of the endometrial glands or stroma is considered to be the gold standard for the diagnosis of disease. And this is very important to exclude these rare incidents of malignancy. I think there's a detailed discussion on imaging modality. With TAS, a characteristic appearance, we can pick up that it is endometriosis, which can be differentiated from corpus luteum. TBS, there is a limitation. It depends upon the highly operator dependent, and it's very, sometimes they can mix rectal endometriosis. Similarly, MRI also, it's very useful to assess ureter, bladder, bowel involvement. But diagnosis of peritoneal endometriosis is not well established. So the biomarker, they were dealt it in detail. So the CDG recommends that the clinician should assess ureter, bladder, bowel involvement by additional imaging if there is a suspicion based on history or physical examination of deep endometriosis in preparation for further management. Because CA125 may be normal, may be abnormal. So we have to rule out before embarking any treatment, we have to rule out the associated condition, which commonly coexist with endometriosis like ovarian disease, paraovarian cyst, fibroid, adenomyosis, bowel cancer, and uterine cancer. So the treatment goals depends. The goal is directed to alleviate pain, to reduce the recurrence, and improve our quality of the patient. So the management can be a surgical, medical, or combined. So the important thing what we consider in this age group is that includes a diminished fertility, and they can go for impending menopause. There is a study says they can go for early menopause. So the diagnosis and treatment for endometriosis associated infertility must be undertaken in an expedient manner. If they come with the infertility problems, we have to take the treatment and expertise the management. So the recommendation by various societies, they endorse hysterectomy BSO. It's a definitive treatment when there is an adnexal mass or a multiple previous conservative surgical procedures is failed or a medical management is failed. So in ESHRE also recommend definitive surgery together with the removal of all visible lesions for women who completed the reproductive area and have persistent symptoms despite medical therapy. So other NICE guidelines and other FOGSI DPR also, actually FOGSI, they are not mentioned about perimenopausal endometriosis, though we had mentioned about, they have mentioned about the endometriosis and malignancy incidents. So almost they have all recommendations are endorsing the same sort of management. The first choice of treatment mainly due to the risk of malignancy. So this age group, they have a comorbid conditions. They may have a previous history of surgeries. So they all should be considered and explained. So there is a risk behind this in this age group, in perimenopause age group, when they embark on a surgery. So all this should be explained to the patient. So before that, we should clinch the diagnosis and we have to rule out irritable bowel syndrome, interstitial cystitis, because they all mimic endometriotic complaints, myofascial and vertebral pathologies. And the surgical technique is highly individualized and should take it into account certain factors like women's age, pregnancy intention, cyst features that itself gives a clue what type of things we are dealing with. And we should consider about the ovarian reserve, fallopian tube patency, and the recurrent status. So all this we have to keep it in mind when we do a surgery. Actually, the ovarian endometrioma is really a challenging. We have to take a lot of decision before embarking that. The surgeons, we may have to use either excision or cystectomy. We can use a vaporization using a laser or plasma energy, coagulate the inner layer using bipolar, destroy using sclerotherapy. But ovarian endometriosis should perform cystectomy instead of drainage. We shouldn't drainage and coagulate, as cystectomy reduces. Cystectomy will reduce the endometriosis associated pain. And following that, we can prevent secondary prevention after cystectomy of ovarian endometriosis. Women who are not immediately seeking conception, we can prescribe combined oral contraception for secondary prevention. And in women operated for endometrioma, we can prescribe post-operative LNG, IUS, or a combined oral contraception for 18 to 24 months. And this is for secondary prevention, and it can reduce the dysmenorrhea and a pelvic pain. And performing oophorectomy rather than cystectomy in women with no further pregnancy intention may be advocated in cases of high recurrence risk. When they are more prone for recurrent problems, even oophorectomy can be offered provided there is no pregnancy intention. So the CDG recommends the clinician should counsel women with endometrioma regarding the risk of reduced ovarian function after surgery and the possible loss of ovary itself. The decision to proceed with surgery should be considered carefully if the woman has had previous ovarian surgery. So surgery plus long-term suppression is very important, and it is based on patient's requirements. If there is unilateral endometrioma, surgery followed by LNG gives excellent relief. Hysterectomy with or without BSO if family is completed or persistence of severe pain. The LUNA is not effective. Presacral neurotomy is effective but creates a new long-term problems also. So the post-operative follow-up is very, very important, either with GnRH analog, combined oral pill, Dynogest, or LNG IUS. So coming to the recurrence after hysterectomy. It is reported in one study 10% recurrent symptoms after TAH, and reoperation rate is about 85% within 5 years. No sufficient data of recurrence after tubal ligation. So the persistent endometriosis following surgery for women with persistent or recurrent, there was a study quoted in that Climatic 2017. Women with persistent or recurrent endometriosis following laparoscopic surgery, medical treatment will be preferred, but we have to be confirmed. Histologically, it should be confirmed, and malignancy or atypia should be ruled out before embarking a medical treatment. But surgery for recurrent endometriosis, management of recurrent endometriosis with conservative surgical approach. Suppose if you have done ovarian cystectomy and the patient again combined with that, she may end up with a oophorectomy. Has been shown to be that conservative surgical approach has been shown to be ineffective. In case of postmenopausal women, there are no data on benefit or otherwise a conservative approach in this low estrogen environment. In a study, 75 cases of recurrent endometriosis, bowel involvement was reported in 33% of the reoperated cases. So it depends. We have to select the case properly. So the medical management, as I already mentioned, it can be a combined oral pill, a norethisterone, Dynogest, GnRH. The new armamentarium in this thing is an aromatase inhibitor, and CDG recommendation in a women with pain from rectovaginal endometriosis, refractory to the other medical or surgical treatment, we can consider prescribing aromatase inhibitor in combination with oral pill, progestogen, or GnRH, since they reduce the endometriosis associated pain. So there is a report, the first report regarding the AI in endometriosis therapy. A 57-year-old woman who had presented with recurrent endometriosis as a painful vaginal polypoid mass And following aromatase AI, the circulating estrogen has been decreased by 50%. Pain disappeared within 2 months. The size of the mass strikingly reduced, and at the end of 6 months of therapy. So we have another thing is an aromatase inhibitor. Whenever there is a deep endometriosis, it is recommended we should refer the woman with a suspected or diagnosed to a center where there is an expertise that can offer all available treatment in a multidisciplinary context. Performing surgical removal of deep endometriosis, it reduces the endometriosis associated pain and improves quality of life. But we need to have a multidisciplinary approach, dense adhesions. And hysterectomy is recommended with the removal of ovaries and all the visible endometriotic lesion in women who have completed their family and failed to respond to conservative treatment. Women should be informed that hysterectomy will not necessarily cure the symptom of the disease. Sometimes the peritoneal deposits may be there. So the tamoxifen and then perimenopause, because most of them will have a breast carcinoma when they may be on tamoxifen. So it may conclude that tamoxifen use might increase the risk of endometriosis, but it induces or promotes endometriosis. It's not clear, but it can increase the risk of endometriosis. So the HRT, there is a lot of benefit to emphasize because they are prone for surgical menopause and which will have a severe menopausal symptoms. So we should not overlook the benefits just because they had a endometriosis. HRT has been shown to enhance bone mineral density, dementia, and cognitive improvement will be there. So we should not deny the benefits. And CDG recommends that clinicians continue to treat women with history of endometriosis after surgical menopause with combined estrogen and progesterone. Progesterone we have to add, though there is no hysterectomy. The only place where we add is progesterone, even though there is no uterus, is the endometriosis. Tubulon will be a better option. The progesterone, what we add, will reduce the reactivation or the recurrence. So there is a study where the total hysterectomy were divided in 4 groups. There was 2% case of recurrent endometriosis and 6% case of recurrent symptom in the estrogen-only group, but none required additional surgical therapy. Malignant transformation was not found, and they concluded MHD was safe. Actually, we have to remember it should be a continuous combined therapy. Both estrogen and progesterone should be given. So the main thread in perimenopause endometriosis is the transformation of malignancy. And the report says it is around 2.5%, and Aries with different type of ovarian cancer, 4.5 to 19% for serous, mucinous, clear cell, and endometrioid types respectively. Ovarian endometriosis is associated with clear cell endometrioid types and low-grade serous mucinous tumors. And usually endometriosis is not associated with high-grade serous tumors or mucinous tumors. So what is the explanation they are offering is, all or certain proportion of cases may be pre-malignant lesion. That's why we are unable to predict which is going to be pre-malignant. They want to make a diagnosis, we need to have a histopathological examination in all cases of before treatment. The environmental, and they postulate endocrinological, epigenetic, genetic factors for both endometriosis and malignancy may be same, and there may be a metaplastic component of the malignant transformation. And the endometrioid carcinoma looked at the relationship, in the Gynaecology report, they have looked at the relationship between endometrioid carcinoma of the ovary and endometriosis. They have reviewed 42 patients with endometrioid ovarian carcinoma and found that endometriosis was present in 11 cases, almost 26%. In 4 patients, carcinoma and endometriosis transition was observed. So they concluded ovarian endometriosis as a potential malignant transformation in postmenopausal women, and it found to be surgically removed. So CDG recommends that the clinician, we should inform when the patient is requesting about the risk of developing cancer, that some cancers like ovarian cancer and non-Hodgkin's lymphoma are slightly more common in women with endometriosis. We should give them that advice. So there are recent studies, they say perimenopause endometriosis associated with early menopause. So they may have a psychological impact due to endometriosis. We need to give them that part of it also. We should take it into consideration. So we need to have an attention regarding the management of endometriosis in the women approaching the end of reproductive life requires a special attention due to the potential risk of recurrence and the transformation into various malignancy. We have to be alert. We need to have a high risk of suspicion. So the endometriosis is not only a disease of reproductive age, it can happen perimenopause and menopause also. When we suspect, when the symptom appear, is already known case or a new symptom appearing in perimenopausal women, we should just have an eye on them. Surgery is indicated when medical management fails, but discuss about the outcome. Conservative surgery is possible in early perimenopause in this era of ART, and when the patient requires need for conception. Risk of malignancy is slightly higher in perimenopause age group. So the endometriosis life starts from adolescence, progress at 30, problematic at 40, supposed to end at 50, the malignancy risk is high at 60, so needs to follow up forever. So keeping an eye on perimenopausal and postmenopausal women, when there is a previous history of fibroid, adenomyosis or endometrioma, we can pick up peri and postmenopausal endometriosis earlier. All that we need to have a high degree of suspicion. So the challenges are that make the life interesting, and overcome them is what makes life meaningful. Similarly, in perimenopause endometriosis also presents a lot of challenges in diagnosis and determining the objectives of therapy, avoidance or delay recurrence. So we can overcome it by appropriate treatment, and we can give them a meaningful life also. And thank you for patient listening.
Thank you so much, Dr. Hepzibah, for your brilliant talk on endometriosis in perimenopausal women. And you have really pointed out the important points that any women who had a previous fibroid or endometrioma, these women, they should be specially followed up to look for endometriosis in their perimenopausal period. And of course, there are challenges in the diagnosis, the risk of recurrence, and of course, the most dangerous one, that is changing into malignancy. So thank you for bringing up all those points. It was an excellent presentation. And now I call upon Dr. Bharti to introduce the next speaker. Dr. Bharti, are you there?
Yes. Otherwise, you continue.
Okay, so our next speaker is Dr. Pradeep Kumar Mitra, who is going to talk on how to create awareness about endometrium for both clinician as well as for the patient. And nowadays we know also for the counselor. I think that was told today in one of the lectures. So we need to create awareness for all three of them. Dr. Pradeep Mitra has done a lot of work in endometriosis. He has been a passionate worker for the benefit of patients with endometriosis. He has been the founder and Secretary General of Endometriosis Society of India. And he is the past president of Bengal Obs and Gynae Society. So welcome, Dr. Pradeep Kumar Mitra. We all want to hear from you.
Thank you, respected chairpersons. Can you hear me?
Yes, sir. Yes, we can hear you.
I think the video is not opening.
Okay, sir, but we can.
I need to share the screen.
Yeah.
Can you see the screen?
Yes, it will come out in few. Yeah, now we are able to see it.
Okay. I'm making full screen.
Make it full screen.
Yeah. Okay. Thanks a lot for kind words. My topic is awareness on endometriosis. And by now, we know that no age or socioeconomic status are immune to endometriosis. In fact, I have just modified a little bit of the title of this lecture. Instead of patients, I just made it public. And in the public, I'd like to divide it into two broad groups. One is adolescent population, it comprises 70%, and the rest of the public comes for 30%, like parents and general populations, fertile couple, women having various symptoms, etc. Now, what is the usual scenario? You are very much conscious and work on various conferences, CME, and live or video workshop. But what is the outcome? Outcome is not very encouraging. In my observation, particularly workshops and other things. In a study, I found around 15 to 30% or 40% people are the delegates. They do have good attention to the conferences and video workshops to improve their skills. But the main question, how much time is being devoted to one, to prevent and detect the disease at the earliest. Number two, arrest and progress of the disease, or to try to revert the disease. And last but not least, seriously think about the quality of life. Now, public awareness on it. We see very often a symbolic awareness program is being kept in any conference, just like this. But this sporadic program in a city has got no effect in the truest sense, as I feel personally. This awareness was invited on me by the living, late legend Professor B. Chakraborty, who is to talk on two words, that is prediction and prevention, way back in 2010. And he said that these two words are the keys to get success against any disease. Now, we all know that 1st March was the World Endometriosis Awareness Day, and then first week of March is often considered as the Endometriosis Awareness Week, and sometimes the entire March, or if not March and April, are often considered as the Endometriosis Awareness Month, and we follow that. But my question is that why not 365 days? Why we restricted it in only 1 month to keep the awareness program? Anyway, 15th World Congress is going to be held at Edinburgh in May, and the last theme was Our Pain is Real. I would like to divide my deliberation into two parts, aware the public and patient first, and then aware the clinicians. This is the approach protocols. Our target population is mainly adolescent girls, and then comes the parents, guardians, and general population. But the most important challenge is how to reach them. We, the clinician, have got a very little to do to reach the grassroots level people. And we need the help of NGOs, which is very, very important, which I want to emphasize. Further, I personally try to motivate the youth, particularly boys and girls from schools and colleges, to come up and help in this work. And then methods for adolescents, school visit program, which may be panel discussion or a solo program, and for others, rest of the population, either all available media may be used or various attractive, innovative ideas are there. I'll be coming up to those areas. Now, school visit programs, types of school, usually girls' school, or sometimes we go for co-ed school, and the students are taken from class 6 onwards. Timing usually post midday meal session after 1, and it takes 1.5 hours, 2 hours. Basic preparation includes preparations of question, training the anchor, one audiovisual system, and plenty of papers. Now, there are 8 points in the protocol which is being modified from time to time, which I had started way back in 2014 from Endometriosis Society India. These are the 8 points. First of all, attendance and registration of the students, and secondly, distribution of slip papers to all the students. Then comes introduction by a principal or representative of the NGO, and then introduction by the conducting ESI member who used to tell how the program would be going on. And at the end, he asked that all the students must write their questions, queries, their problems. They should mention the age only and not the name. And all their questions would be answered by the person from ASI. Then questions, and this is the question and answer session with the audiovisual. You can see one anchor is there who is asking question one by one, and the person from our end is answering the questions. These are the other steps of the various other questions, like what are the special diseases found in adolescent girls. Then what is the relation between menstruation and endometriosis? Now, we probably, we mostly wanted that all the girls should have a basic impression of the disease and the basic impression of the reproductive organ, particularly visual impact of the pelvic organs, reproductive organs, and of the disease as well. Now, basic events have also been shown like this. Why the disease occurs, we also don't know as of now. And when the patient comes to us, this is the condition, that's the tip of the iceberg with complaint. They should have an idea how endometriosis implants looks like, and then how it is being diagnosed as with the typical complaints, with or without family history, the first relatives, and ultrasonography might be needed. They should also, we try to inform them the normal and abnormal feature or picture of pelvis in endometriosis. I found that all these girls, they know this particular term, like ultrasonography, microsurgery, or laparoscopy, chocolate cyst, biopsy, etc. These terms are not unknown to them. Then how to approach? Awareness, awareness, and awareness. This is the one word. If painful menses occur, report to a doctor or consult gynecologist. Why? For starting initial treatment or management and for confirmation of the diagnosis. Now, what are the intention of the treatment? First is symptomatic relief and arresting of progress of the disease. Then successful pregnancy in the later part of the life, and last but not the least, lifelong better quality of life is to be achieved. These are the other questions which can be modified time to time. Now, about the incidence, is it rising? Yes, definitely. This has been discussed earlier in our study from Endometriosis Society India. We found that 5% of the girls below 18 years, way back in 2007, who complained of dysmenorrhea and chronic pelvic pain, would be going to have endometriosis in future. But what is the present scenario? In our last study in 2017, we found that 1 out of 3 girls who are having the same problem are going to have endometriosis in future. That means incidence rose from 5% to 33.3%. Then add-on factors, the role of modern lifestyle, the 10 dangerous foods for endometriosis have been shown to them, and these are all delicious foods from sedentary habit, which is very, very important. And then the adverse effect of using too much use of mobile phone without taking any exercise has been emphasized to them and discussed with them. Then how can we prevent or the disease or the progress can be arrested? So for prevention, I think awareness and change in lifestyle is most important. This is just skipping this slide. In lifestyle modification, the 2 areas I feel important. One is change in food habit, and the other one is exercise. The next step, we have just ended the lecture or panel discussion. Next step is to collect the slip papers. You can see the slip papers from the students with a lot of questions, and a PhD thesis can be made from all the questions they made. I'll come to that later. These are the questions of the, you can see. On analysis of the 2 student problems, they found that all the students had multiple problems, of which dysmenorrhea with or without CPP was the commonest. This is the list of programs done in 46 schools way back in 2018, and every year we'll continue the same, except some part in the during COVID pandemic. Now, let me share some pictures. These are the awareness programs done at Assam and Shilchar, 2016. Some pictures of 2017 in English medium schools. These are some pictures in North Bengal in 2017, and then some local school and 2018. And last program before COVID we held there in North Bengal in February 2019. And this is the first program in the conservative community. I had to face a lot of objection from the administration to get into the school. However, when they allowed me, and at the end, on their request, I had to stay back for 2 days more there to promote this program and continue the program in 8 more schools of Muslim community. This is the program we did after the COVID. Now, recording of the total program. One good program had been recorded. Why? Because train the class teacher, and I usually handed over a CD or a pen drive of the entire program so that the principal or the class teacher can take initiative to teach or just continue the program throughout the year. It's not possible for us to go over there every time in all the remote corners of the India. My observation, all the students were very attentive. They wanted to know more. They want to ask many questions, and their questions were very specific and intelligent. Teachers were equally keen to learn and the impact, and they wanted to interact for their own problems. The time where I thought it would be finished by 1 hour or 1.5, but ended up at 2 hours or so. So the general overview on school visit is that an initial period, in the beginning, is very difficult to perform, but at the end, it lands up with success. And these are the various letters we often get, that please come again, and please come. Side by side, we are doing awareness program on patients and guardians. And we also continue the program where both the students and the guardians are there as audience. As you can see here, I felt some active support is needed. And why? There are 2 areas I feel. One is how to continue this program to cope the demand. And the second one, how to offer some positive support apart from awareness only. To cope the demand, we have set it up local team, as I've already said, involve the teachers and senior students, and to run in the form of webinar or online. But what about positive support? A girl suspected to have endometriosis, we are trying to provide support from our members of ESI, the team ESI, or from some government hospital to offer the basic management, and more involvement of the media is needed. Then comes the general population. We have divided into 2 groups. For urban areas, various public address systems like TV programs, radio, articles, write-ups, etc. Then comes use of TV news channels. This is very important. At the end of all programs, TV coverage was done. Most of the time, we tried for that. We also continue this similar TV programs even now in different channels. And this is one historic TV program where you can see late Professor B.N. Chakraborty and Dr. Dashbam is there. And this particular program had enormous impact on the society at that time. Other more effective methods in 2023 are WhatsApp, Facebook, Twitter, many newer modalities that can be used at present. Now, festival and awareness. It started at Puja Parikrama. You know, Durga Puja of Kolkata is very important festival. And here, our youth youth brigade. They used to take the senior citizens to those puya pandals, and you can see very clearly. You can see they're holding some yellow banner or yellow poster, which shows the various important facts on endometriosis, but endo awareness, which has got enormous effect in the city areas I have seen. So they are doing the social work along with mass awareness, as you can see, in different areas of the cities of Kolkata, also in different rural parts. Now, stage show, road show, and group chat are equally important, and I found one impact of this while integrating them in awareness programs. Then comes what we can do in the rural area. The impact of roadshow and rally appears to be very important. Here, one rallies like this Endo rally is going to be started, and you see the rally. The mothers, here the adolescent girls with their mothers there in the rally, and they're also holding the posters with their messages, various messages. This is evening, and here is another one. This is the largest rally we did there in North Bengal. You see how disciplined are those village women, and they are joining the rally in a very systematic manner. More than 700 women were there, so far I recall, in that particular rally, and they hardly saw this type of rally in the village. As you can see, I'm just making it short because it's a big rally. They are accustomed to see political rally in various areas, but they have never seen this type of rally for a particular disease only. And this is a big rally, you can see, and this has got enormous impact on the villagers and in the rural areas. We are trying to continue the same in the entire part of the Bengal and other states as well. Is the biggest rally. And then this also contains various messages. These messages are very important. These are written in Bengali, but we use regional language. This has got enormous impact. The people in different points, they start asking the organizers, what is the meaning of these posters? What is written over there? And in this way, the awareness could be spread in different parts in a very effective manner. And I felt this is a very important one. You can see this remote rural area, this type of rally. They are covering the entire village, and they are spreading the awareness on endo to all those people who are there or who are observing this awareness. Then continue. We went on with awareness program from the parents as well, as you can see over here. And then, as I said, and my previous speakers also say, all age groups are there who may have endometriosis. So youth guiding the elderly women for making them aware regarding peri and postmenopausal endometriosis in different areas. Then comes the second part of the lecture, that is awareness for the clinicians. I feel that teaching, training, and practice is very important. First group, there are two groups also here. One is awareness for OB/GYN specialists, for which special seminars, CME, or panel discussion, etc., are done in different zones. And the other group comprises the other specialists, general practitioners, non-allopathic medical practitioners, paramedical staffs, nurses, rural health service providers, etc. For them, general seminars on endo is being organized. The other 2 areas are points I'll discuss later, just immediately later. These are the special seminars for OBGYN specialists on endometriosis. This has been done in Shilchar with the help of Shilchar OBGYN Society, and in almost all the societies we're trying to do with the help of all these societies. And then to aware other specialists, general practitioners and paramedics, we went on with the help of private multidisciplinary, multi-specialty hospitals, with the help of IMA and local administration. And you can see the doctors and paramedics are sitting over there, and I was flooded with questions because they are much more intelligent, and they started asking good number of questions, why this has happened, why this thing, that thing, etc., etc. Then lastly, asymptomatic endometriosis. We all know that it accounts for more than 10% of the cases and only being detected while doing investigation for infertility. I propose that communication and request to our sonologist and general surgeon, general laparoscopic surgeon, to go for a detailed pelvic mapping while doing ultrasonography, abdominal laparoscopy rather, or laparoscopic surgery in abdomen for any non-gynecological condition, by which many asymptomatic or undetected endometriosis will be refilled. Then comes mass awareness with the help of general physicians. They have got enormous role. A paper was published in New Zealand way back in 2018. I have modified it to some extent. It has got two parts. One is the waiting room survey, leaflet on endo screening questionnaire. As you can see, these questions, basic questions, these are there in the leaflet, and all the patients who are attending the clinic, this questionnaire format leaflet was handed over to them from the reception, and they were asked to fill it up in the waiting room area. And when the turn of that particular patient comes, she handed over the leaflet to the general physician, and the general physician at a glance could screen out any suspected case so that she can be advised to go for earliest referral to gynecologist. The other one is display of posters on endometriosis. In my personal clinic, I used to prefer to put up this type of posters containing symptoms of endometriosis. It can be placed in general gynae and various hospital premises and other places. And these are the other posters that I prefer to place in the different chambers. So, take-home messages include pain during period, chronic pelvic pain, and other vague symptoms in adolescent period should never be taken casually. 1 out of every 3 such cases will develop or land up in endometriosis. Endometriosis asymptomatic for a long time. The first problem may be the form of failed responses, and then endo is a progressive disease with chance of recurrence and refractoriness to various treatment modalities. It may cause significant reduction and diminution in the quality of life without causing death, unlike malignancy. So, earliest detection, arrest the progress, control of the disease, and lifelong monitoring, I think, might be the idea. Endometriosis Society is using a public awareness program to fight for endo, to help end endo. And I would request everyone, please join Endometriosis Society India. And thank you for patient hearing.
Thank you, Dr. Pradeep Kumar Mitra, for your wonderful deliberation. I salute your dedication for creating awareness for endometriosis at all levels, right from puja pandals to schools to NGOs along with IMA meetings. So thank you so much. I think all of us should have this jazba to create awareness whenever we get an opportunity. So now we have the next speaker. I would also request the speakers to kindly maintain time because we're already running late. So our next speaker is Dr. P. Sizers. He is the chairperson of the Midlife Management Committee, and he's also the Joint Secretary of Kerala Federation of Obs and Gynae Society, a very young, enthusiastic, and a very lovable person. So Dr. Sizers, now we are going to hear from you that how can we manage stress in endometriosis. So over to Dr. Shaija.
Thank you. Thank you. Shall I share my screen?
Yeah, sure.
I hope my slide is visible and I am audible.
Yes, yes, Dr. Shaija. Please go.
Thank you. Thank you. First of all, a big thanks to Lakshmi Shrikante madam, the ICOG chair, Ramani madam for that invite. And thank you for placing this relatively out-of-the-box topic in front of me. I think it's always a pleasure to take up such challenges and attempt to do well. Thank you to the entire team of FOGSI and ICOG for such a wonderful program. I think endometriosis need to be talked about much more than what we are doing at this point of time. Now, stress and role of psychological counseling in endometriosis is the topic for the day. I would say that it's an irony that the need to talk to your patient happens to be a relatively less talked about topic in endometriosis. So that was just for the play of words. I've always felt that whenever we talk about this disease called endometriosis, there's a definite discrepancy between what we offer versus what she actually wanted. We generally offer her the best of surgery for endometriosis, which lasts for hours together. We also offer her the most updated and the evidence-based medical management, which lasts for months or years together. But what did she actually want? She just wanted 15 minutes to sit down and talk to her doctor on what she was actually going through. And unfortunately, we couldn't offer that. So we need to look at that discrepancy and try to offer her what she actually wants. We all understand that endometriosis is quite a bad disease, primarily because of its chronic nature, pain being the most distressing symptom, the recurrent nature of the symptoms because it's going to trouble her almost every month, the associated infertility, which is a social problem too, and even her partner, her family, everybody is going to be involved in that. High rates of recurrence for the disease, even after a very extensive surgery. Now, I'll introduce this term called medical trauma. I'm not sure how many of you have heard this. We have all heard the word called trauma, which is a term that we associate with an accident, with war, or something like a sexual assault, the most distressing one of all. But this term called medical trauma, it accounts for diagnosis or treatment of certain diseases or certain medical events that can result in trauma symptoms. I repeat, these are diagnosis or treatment of certain diseases or medical events that result in trauma symptoms. And unfortunately, a chronic disease like endometriosis is likely to result in medical trauma. So get used to this terminology called medical trauma. And as we go on, we would be using this word and trying to explain it in a little bit more detail. Now, what are those factors related to endometriosis which accelerates the medical trauma? One is clear-cut, the thought that the symptoms are going to be there almost lifelong. The first question that she always asks is, what is that ultimate cure? And when is she going to be symptom-free? And the answer to that would be that she might have to live with the symptoms for lifelong. The fact that repeated calls for help are being needed. We always talk about the distress for a gynecologist when a suffering endometriosis patient keeps calling her up with repeated phone calls. But just think from the other side. She is also suffering because she needs to make these phone calls to you on a repeated basis and she doesn't have a real cure for it. The intensity of pain for her is almost unbearable. A pain at sex that points fingers at her sexual potency as well as her marital relationships, which is quite traumatic. The thought that the symptoms are to be expected almost every month. The fact that it can affect her childbearing ability. Her partner or a family losing interest in her getting the right treatment, cost implications. I think the importance of that cannot be overemphasized, especially in a country like India, where the patient bears the entire cost of her treatment. When we are concerned about providing her with the best cytoreductive surgery to clear the disease, she's having the fear, on the other hand, of losing her reproductive organs. And the thought that even after all this, the disease can still recur. And that really, really hurts. Are we gynecs adding fuel to the fire? Honestly speaking, I will have to say that it's an unfortunate yes. In this era where there is so much of medical legal implication, we try to be honest with our patients. And in an attempt to be honest with our patients, we often get brutally honest. Studies have looked at certain comments which have been made by the gynecologist as the most distressing ones for their patients. You want to know what are those questions? We make such a comment that the pain is in your head and not in your vagina. And sometimes the pain caused by such a comment can be even more hurting than the pain of endometriosis. Can't she bear a little bit of pain? How was she in her childhood as far as pain tolerance is concerned? These seeds of doubt that you're planting about her integrity is going to disturb her every minute, every hour, every day of her life. Her partner is going to repeat this. Her family members are going to repeat this, and she's going to suffer. And here comes the new term called gaslighting. It's really not a new term. I'm not sure how many of you are aware of this term called gaslighting. But if you're not, then I think we need to understand this terminology and this concept a little bit more better. Now, gaslighting is a form of psychological manipulation that is used to gain an upper hand over a person. One person attempts to create a self-doubt or confusion in the other person's mind to gain that upper hand. And there are multiple articles from around the world which have been written on the rampant gaslighting that is happening amongst the medical fraternity, especially when they're dealing with patients who suffer from chronic diseases. And that is where we need to be really, really concerned. So avoid any of those questions which are creating a kind of self-doubt and which will lead to self-blame in your patients, especially those suffering from endometriosis. Now, understand that endometriosis doesn't just affect her pelvis, it hurts her mind too. Studies have categorically stated and looked at incidents of almost 80% plus of depression, 60% plus for mood disorders, and close to 30% of moderate to severe anxiety when they have significant degree of endometriosis. The added problem of the delay. On an average, studies have shown that it takes more than 7 years to get a correct diagnosis of endometriosis from the point of time they meet their first clinician. Add on those years which she is taking in addition to reach a clinician after suffering from symptoms for long, and just introspect and understand that the self-doubt that we knowingly or unknowingly create in them too may be contributing to this. How to overcome this? Now, one way to overcome this is to have a protocol for therapy. Remember the fact that when the leading symptom is pain, she might very well be a candidate for a surgery. So if you in case have this concept of a medical management for 6 months as a rule for all, that really, really hurts the treatment process. When patients show too much of distressing symptoms, psychological care instead of medical care often gets advised. You just refer her to a psychiatrist and then you wait for her to come back. And that's absolutely wrong, because psychological care should be one which is in addition to the medical management that you're giving, that would cure both her body as well as her mind. And that should be the norm, the combination of psychological care as well as medical care. What are the components of psychological counseling? One is a patient-oriented, or what we call today as a customized counseling strategy. It's not a blanket plan for all, like the one pill suits all. It's not a one plan that suits all. It's totally customized. We need to first listen to her, understand which part of endometriosis is hurting her body or her mind. Understand and try to give a solution to that. And what has come up recently in a big way is something called a self-care-based counseling, where she's made aware of the disease over a span of 3 to 6 months and she is involved in every decision-making process. So she is in full control of what is going through her treatment. She knows about it before itself. She understands what has to be expected out of it and how she is going to manage her day-to-day life living with this disease. And that will help her control her emotions better, helps her to adhere to the therapy, helps her understand the treatment plan, helps to improve the quality of life, reduces stress, reduces anxiety. She feels much more secure and more satisfied with your treatment. What are the techniques that are used to train her mind? One is the time-tested progressive muscle relaxation. Anybody who has had a slump as far as your mental health is concerned would have been told about progressive muscle relaxation, where you contract and relax your muscles from your head to toe, and you feel it, and you feel much more relaxed at the end of it. Self-care based counseling, about which I already talked about, allows them to accept the situation as it is and accept the person as they are. And that has to be a 3 to 6 month long awareness program to know their disease better. What do we generally do in our OPs? Like a 2-minute trailer of a 3-hour long movie, we talk about their disease and the most distressing aspect of it over a period of 5 minutes, and she totally gets psyched out. There's no better word to use. So this awareness program has to take some time, and she slowly need to be introduced about the various aspects of endometriosis, and that helps her manage her disease much better. There should be a definite intervention to make her understand her sexual function. Why she is feeling pain, if it is only the deep penetration that causes pain, how she can avoid that, and all that. And anything about sexual function as always has to be in combination with her partner, because that's where the entire blame comes from, and even her potency and a marital relationship can get questioned. Now, before I leave you, a few take-home messages. We all understand that endometriosis is a bad disease, not just for the gynecologist, but for the patient too. Understand the entity called medical trauma, which is trauma symptoms because of a diagnosis or a treatment of a medical condition, especially the ones which is distressing and chronic as endometriosis. Unknowingly, we gynecologists too may be contributing to it. Gaslighting should be totally avoided. Never ask a question, never pass a comment which creates a self-doubt in her, which causes her to a state where there is an amount of self-blaming. Remember that endometriosis is not a disease of the vagina or the pelvis. It can hurt the patient's mind too. Choosing the right treatment for her holds the key. It's not medical management for 6 months for all before attempting surgery. If pain is the leading symptom, you might well have to do a surgery at the first hand in the best hands possible. Relaxation methods and self-care based counseling should go hand in hand, not just refer to a psychiatrist and then sit back and relax. It always has to be a combination of psychological help plus the medical treatment, and that's going to do wonders. So if you have taking home these two terms called medical trauma as well as gaslighting and help your endometriosis patients deal with the disease a little bit better, I think the purpose of my lecture is fulfilled. That is my time. Thank you so much for being a wonderful audience.
Thank you, Dr. Shaijas. Indeed, it was a very enlightening lecture. We liked it very much. And the word mental trauma is now engraved in our mind. Medical trauma.
Medical trauma, yeah.
Yeah, medical trauma. It is now engraved in our mind. So with this, I think we don't have time for discussion. We're already running late. So we straight away move to the panel. And we have a very interesting panel on medico-legal issues in endometriosis. And the expert for this session is Dr. Parag Biniwale. We all know him. He is the chair ICOG. And he is the president of Pune OBGYN Society. He has been the past chairperson of Young Talent Promotion Committee. So welcome, Dr. Parag. And he'll be giving the opening remarks today. And the panel will be moderated mainly by the expert in medico-legal. We all know him as the person who is associated with medico-legal, the past chairperson of Ethics and Medico-Legal Committee, Dr. MC Patel, sir. And he has a galaxy of panelists with him. The first is Dr. Deepa Mukundanan, who is from Trichy. Dr. Shobha Gutti, we all know she is an ICOG Governing Council member as well as past chairperson of Family Welfare Committee. Dr. Arul Moji, again a brilliant clinician from Bangalore. Dr. Gayatri from Trichy. Dr. N. Palani Appan, past chairperson of Safe Motherhood Committee. And next is Dr. Krishna Kumari, who is past president of Hyderabad OBGYN Society and also She is the national corresponding editor of Jyoti. So with this galaxy of panelists, I hand it over to the experts and the moderator for the panel discussion. I think Dr. Hitesh Bhatt has not joined with us. And I would just make a very humble and gentle request to the moderators that please try to finish the panel in 40 minutes because we're already running late. And then after that, we'll have the post-test evaluation. Thank you.
Dr. Gayatri is not joining today because of some problems. And I would like to add up that Arulmozhi is also a medical legal consultant.
Okay, that's very
Her
great.
postgraduate diploma in medical legal law. See, that is why I was very keen that she should be there.
Okay, welcome, Dr. Arulmozhi.
Yeah, thank you, Dr. Abharani. At the outset, let me thank Dr. Lakshmi Srikhande for coming up with the weekend. This is the beginning of the week, a short course on endometriosis, and of course, our own Dr. Ramani Devi and Dr. Asha Rao, who are the past and current chairperson of the endometriosis committee and doing a brilliant job. When we talk about endometriosis, it takes me back 32 years ago. When I was a student in Pune, we had a lecture by Dr. Nargis Motasha, who then talked about a condition called endometriosis, which was essentially a disease of Western world. And we were all surprised, shocked, and even thrilled to see her laparoscopy pictures. And we always wondered what it would be like. But now all of us will agree that endometriosis is so common and so rampant in our country. All of us should understand the disease in toto in order to treat our women who are already distressed very well. So any disease has its own issues. So women suffer from medical illness, mental illness, which was brilliantly brought out by Shaijas a few minutes ago. And now we as healthcare providers of women are also troubled by the medical legal field and the litigations. So whenever we are treating any woman, we always have to keep in mind that whatever we give it to her does the best, but in some situations, there may be problems where we are in the soup, and then we have to take help of somebody like Dr. MC Patel, who will today, through the panel discussion, will guide us as to how to manage medical legal issues as far as endometriosis is concerned. So be it the diagnosis, be it the medical management, the issues related to surgery. So in next 40-45 minutes, I think it's going to be a good learning experience for all of us to understand the medical legality of endometriosis. Over to you, Dr. MC.
Thank you, Dr. Parag. Let me share my screen. So 45 minutes given to us for this panel discussion, and when 5 minutes are left, please warn us so we will conclude the panel. So greetings from Statue of Unity, tallest statue of world, and we all are proud of that statue. Warm welcome all the delegates and wishing you litigation-free practice. At the outset, I would like to thank ICOG team and Dr. Asha Rao, Dr. Ramani Devi, and Dr. Abharani Sinha in particular for inviting me as a moderator to share my views about the subject. Medical legal challenges in management of endometriosis. So we just heard Dr. Parag Biniwala, expert for this panel, and learned panelists Dr. Deepa Mukundan, Dr. Shobha Gudi, Dr. Arulmozhi, Dr. Gayatri, Dr. Palaniappan, and Dr. Krishna Kumari, whosoever are present on the panel. And question is not to specific panelists, it is to anybody one can take. I never learned from somebody who agreed with me, and if two people agree on everything, then one of them is not required. But in this panel, let us see how they differ in their argument and comments. So usually I start any of my panel with this question: is it worth discussing? Any panelist can take. Is it worth discussing?
Yes, of course.
Why? If it is yes, then why?
Why? Because this is, as we've seen through the various lectures, is a terrible disease, and it can take any turn at any point of time in life. And the patient and her family need to have answers for several questions. And if one question can have 10 answers, it's possible that the doctor can be pushed into a medical legal situation at any point of time, and we need to be ready with our answers.
Yes. So anybody else to add anything, or should we go further?
Can I just
Oh, yes.
add a sentence?
Yes. Oh, yes.
Yeah, good evening, everybody. Thank you for including me in the group. I would like to just make a statement that we all know that starting from the theories to the treatment to diagnosis, it's continuously there is a continuous change. So it's very important that you all keep yourself abreast of what is happening with the knowledge. It's otherwise the patient is going to be more, I mean, there's always medical jousting. I think that's one word Shaijas hasn't used, but I would say that there is always a possibility of medical jousting also, which will also put us into trouble, not only our treatment itself. So it's very important that we keep track of everything that's happening around us and continuously be updating. Thank you.
So as far as
Can I
medical
just add a
legal,
word?
yes.
Good evening, everybody. It's great to be in this session. This is a disease of lots of twists and turns and a lot of unanticipated issues. I think that's the crux of why we should be discussing this today.
Yes. Now, as far as medical legal part is concerned, whenever disease is like endometriosis, it is chronic one, and recurrence is also known with it. So many times it goes with litigation. And as per statistic of medical legal part is concerned, medical litigations are increasing in number constantly and steadily, and unluckily we gynecologists rank first. So that is why in our conferences, workshop, CME, webinar, now it has become very essential to discuss medical legal issues as far as related topic is concerned. Because in our day-to-day life, as far as any case of endometriosis is concerned, we take utmost care of any of our patient, but we never know. Accident may happen at any time, and it may invite litigation at any time. So face the litigation and pay compensation, because there are so many issues in our day-to-day medical practice, including endometriosis. So which are the areas for litigation in management of endometriosis, particularly when we are managing any case of endometriosis, which are the areas which may lead to litigation in future? So anybody can take.
First, it could be diagnosis itself.
Very good.
We don't have a very sure way of diagnosing an endometriosis. That is not 100%. So first, it could be diagnosis. Then it depends on what you talk to the particular patient about the diagnosis or about the management, because there are patients who will even record what you talk at the moment and then can produce in the court of law after some time. And so we need to be very careful in what you talk. So you need to talk very sweetheartedly to the patient and then probably gain her confidence. That's the second thing after we know that it is an endometriosis. And so diagnosis could be very difficult as far as whether it could be clinical symptoms, or it could be CA-25, or it could be, ultrasound or MRI or whatever. And we need to be quite careful because there's no one answer to this particular disease. And then, of course, preparedness for treatment, and then, of course, treatment modalities. And so we could have litigations in any of these aspects.
So let us discuss for diagnosis first. Very rightly pointed out that diagnosis is also one area where one may end up into litigation. Delayed in diagnosis or investigation or treatment could be one area for litigation as far as treatment of endometriosis is concerned. And misdiagnosis. If you have missed the diagnosis of endometriosis, and it may create some problem. And wrong diagnosis, if it is a case of endometriosis, and if your diagnosis as something else and you're treated like that, then also it may invite litigation in this type of situation. So very nicely pointed out as far as diagnosis part is concerned? Yes, any other panelist as far as diagnosis, or we may switch over to another area of endometriosis management? Anybody? As far as diagnosis is concerned?
Fully agree, sir.
Fully agree.
Yes, sir.
Complications. When we deal with a case of endometriosis, we have come to the diagnosis. Yes, it is a pakka case of endometriosis, and now we are managing the case, and some complications occurs. So could be we have planned medical treatment, and there could be some side effects of medicine, and it may invite litigation. So can anybody throw some light as far as medical management of endometriosis is concerned, and risk related to medical, medical legal risk, or not other risk when we are discussing medical legal issue. So medical legal point of view, I am asking as far as medical treatment is concerned.
So when medical management is offered and given over several months in time, it is going to it is going to also lead to a delay in conception. So the partner may be upset, and if not adequately counseled about it, this can lead to a complaint.
Yes.
And similarly, side effects, if something like GnRH is used, we all know the side effects of such strong drugs, and those can become issues in practice.
So side effect of drug itself is also could be one of the area as far as litigation part is concerned. One more area, if we go for surgical management, then can surgical management of endometriosis be considered as a fertility enhancing surgery?
Only sometimes.
Only sometimes.
Meaning most situations, the indication would be pain, to relieve pain.
Yes.
And to bring down large endometriomas, which are causing other symptoms.
Because in case of fertility and endometriosis, if you offer surgical management and if she doesn't conceive, then it may invite litigation. So surgical management of endometriosis cannot be considered as a solely, not in all the cases, fertility enhancing surgery. But if I specifically mention, if it is a case of endometrioma, 4 centimeter, and if there is no pain and patient has come up with infertility, would you like to suggest a surgery?
So I wouldn't offer her surgery, sir. It's only 4 centimeters and she's asymptomatic and she's not conceiving. Then I wouldn't probably offer her surgery. I'd look for some other cause also.
So with endometriosis, you would like to go for ovulation induction on any IVF treatment?
No, I didn't say that. I wouldn't think in terms of going for IVF straight away. There are enough experts here, and I'm sure that will land up in a debate, and we will have medical legal issues here itself. I don't want that to happen. What I'm trying to say is a 4 centimeter endometrioma, we can always debate on whether you want to operate or you want to give medical management. And so I probably wouldn't. And so putting a scope or doing a surgery in a 4 centimeter endometrioma who's asymptomatic and been incidentally picked up, I wouldn't operate her because that itself would invite a litigation.
Yes, so very good. So one more thing, as far as surgical management of endometriosis is concerned, we should also keep in mind failure of procedure or operation, trauma, injury, hemorrhage, possibility of infection, complication of anesthesia. So whenever we offer surgical management as far as endometriosis is concerned, these are some areas of risk related to that as far as medical legal implications are concerned. Injury to surrounding structure is one more area. When we are doing any surgery for endometriosis, it is very much known. So can one throw light about this? Injury to surrounding structure at the time of...
Yeah, most common is the ureteric injury, which we can think of.
Yes.
And of course, when they're operating on very The deep infiltrating ones, injury to the bowel is also more, it needs, it's very important. First thing is you counsel the patient and tell them that what are the possible complications that can be expected, and to have a specialist available, and to take all the precautions necessary, and it should be done by a very well-trained person. These are the only ways that we can escape, especially when we are operating upon a very severe degree of endometriosis.
So injury to surrounding structure like any ureter, urinary bladder, bowel, and some important vessels also we should consider. Because in this very recently decided this case in National Commission, it was case of severe dysmenorrhea with infertility, deep-seated endometrial nodule on sigmoid colon, advised laparoscopic excision of that nodule, and during surgery there was injury to sigmoid colon. Colostomy was to be considered, and naturally when colostomy was considered, after some time second surgery to close colostomy and anastomosis again, and this patient and patient party went into court, case was filed, and very recently compensation was demanded 11 crores, but National Commission awarded only 42 lakhs, considering negligence on part of treating doctor. So in this type of situation, let us discuss where thing went wrong, or when thing goes wrong in this type of situation, and how we can tackle not to end up into medical legal issues as far as surgical management of this type of cases are concerned. Yes, anybody can take.
Can I take this?
Yes.
I think pre-surgery counseling is the most important thing. Many times we are not aware of the extent of the disease before we go in and actually look at it laparoscopically. So lots of surprises during surgery. So it's very important to take appropriate consent from the patient on what you are likely to do, or let's say, suppose the ovary is entire ovary is stuck to some bowel or something, and there is a need for bowel resection or something. I think appropriate consent will have to be taken even prior to the surgery, and I think all the complications should be explained. We might think it's a small issue, but when we go in, it might be a bigger issue.
Yes. And one more area we know is recurrence. Whatever treatment we offer, medical or surgical, but we cannot give guarantee as far as recurrence part is concerned. So it is all likely. So these are some area as far as diagnosis is concerned, complication related to treatment, medical or surgical, injury to surrounding structure during surgery, and recurrence are the area for litigation as far as management of endometriosis is concerned. And many times these are some other issues also, which could be very common allegations, unnecessary investigations, no proper consent. We will discuss consent later in depth. Staff not qualified, infrastructure issue, emergency services not rendered properly, communication failure, delayed in transfer. If at all we have to transfer patient to higher center for some reason, and if it is delayed, then it could be also one area as far as litigation is concerned. Morbidity after treatment, or when diagnosis is delayed and some morbidity happened, then it is also one area for litigation. In few of the cases, mortality, overcharging, this is very common allegation nowadays, tremendous expense against unexpected result. Because we know as far as any treatment part of endometriosis is concerned, whether medical or surgical, we cannot give 100% guaranteed result. And when there is a tremendous expense, then it is also one area as far as litigation is concerned. If patient has asked for medical record and we have not provided, then also it becomes a one area. So let us discuss very quickly as far as medical record is concerned. If any patient asks any record of treatment given, should we or are we bound to give?
Yes, so we should give. We are bound to give.
And how much
cannot
time? Any guideline on part of MCI or NMC?
72 hours?
Yes, previously as per MCI guideline, it was 72 hours. But now with latest
24
guideline,
hours.
NMC, 5 working days. Within 5 working days, you can provide medical records to the patient or patient party. Many times you will be experiencing that patient is having a mediclaim. You have treated patient for endometriosis, surgical method, or so any other method, and patient has claim for medical legal, a compensation, and some insurance people comes to you and ask some detail or record of that very patient from you. Would you give? Can you give?
Yes, we should.
We should.
Sir,
anybody would to differ?
I would like to differ, sir.
Yeah.
I will not
Even I would like to differ. Patel
Yes.
sir, good evening, sir.
Good
Namaskar.
evening.
Sir.
Welcome, Shobha.
Yeah. मुझे लग रहा है कि इंश्योरेंस को देने के पहले कुछ फॉर्मेलिटी होता है शायद कि कंसेंट लेना पड़ेगा पेशेंट के से या फिर हॉस्पिटल अथॉरिटी से.
Very nicely picked up, Shobha.
Yeah.
As far as any medical record of any patient is concerned, without permission of patient, you cannot give record to anybody.
Correct.
Insurance people or anybody. So in this type of situation, if you want to help to the patient also, of course, it is your patient, she has given you a payment, etc., and she has gone for reimbursement. So you tell that insurance people that whatever detail of record you need, you ask to the patient. Patient will come to us and then we will provide. Or you have a authority letter from patient that whichever record related to my treatment can be given to this fellow, then only you can give record to any other person.
So I have a point to add here.
Yes.
If the insurance company has a specific query on a specific part of the treatment, we certainly the hospital responds by explaining that particular point. This has happened and it has been happening.
Usually, madam, in this type of situation, insurance company will address that query to the patient, not to the treating doctor.
So it's a direct letter to the hospital and treating doctor, and the hospital has asked the treating doctor to give an explanation for it, and it is generally a non-committal answer, which doesn't harm the patient.
So usually, in this type of situation, if at all any query, insurance company will address to the patient that solve this query. Patient or patient party will come to us with this query, and usually we give answer to the patient, and patient submits all this reply to the query to the insurance company. Usually in my practice, I have observed this. But if insurance company directly approaches hospital, then just we discuss. We should ask the patient or have an authority letter from patient.
Can I just have a word, sir? Actually, there is a difference between cashless treatment claim and reimbursement. If it is a cashless thing, it is the patient who is asking us to proceed with the cashless insurance approval. And then we are, with the consent of the patient, obviously, we are going to submit all the records. If it is a reimbursement, as you put it right, I think we can give it to the patient, and the patient will be the point of communication with the insurance agency. But if it's a cashless, it's usually the queries come to the doctor directly or to the hospital authorities directly.
So whenever this type of communication comes directly to hospital or treating doctor, we should inform patient that this type of communication we have received. Should we entertain this or we should not? If patient is ready, then we can give, no issue. But it should be to the knowledge of patient, whichever correspondence we have about treatment given to third party, whether it is insurance people or anybody else. One more area, failure of patient to comply with schedule follow-up. Many a times we advise patient to come for follow-up, and patient fails to come for follow-up and she suffers. And many times there could be allegation that a doctor didn't give much attention to my treatment part. So yes.
So this suffering is what we refer to as contributory negligence by the patient,
Yes,
and
exactly.
it is suffering.
So
it's because of hers.
when patient doesn't follow your instruction, then it becomes a contributory negligence on part of patient. So it becomes a good defense in your favor. So, but burden of proof is on your shoulder to prove. Then how we can prove? Say, for example, at the time of discharge, in discharge care, we will have to mention about diet, about exercise, about medicine to be taken, and about follow-up visits. So if we have mentioned that come for follow-up after 7 days, and one more sentence we should write rather, if any emergency, if any complaint, then you may visit hospital at any time. And if patient doesn't turn up after 7 days and some complications happens, it becomes a good defense. So make a habit to enter in your record every time. Whenever patient comes late, then also. Many a times you will be experiencing that person who is accompanying the patient will complain about patient. Doctor, she is not taking medicine properly. She is not taking milk properly. She is not taking diet properly. Mention in the case paper. Patient not taking medicine properly, history given by mother-in-law. This simple sentence becomes a good defense in your favor whenever you are facing any litigation in any court. So we discuss all this now, what to do and how to prevent all this litigation in our practice, because whenever we are facing any litigation related to endometriosis management, this is a very simple and usual question on part of prosecution. Was it preventable? And usually you cannot say no. Of course, we cannot prevent endometriosis, but other part. So this question is asked, was it preventable? And if it is yes, then one more question we will have to face. What did you do to prevent it? Whether complication of management, whether injury to surrounding structure during surgery, everything will be covered in this question. So what did you do to prevent it? One more area, if you couldn't prevent, then one more question, why you couldn't prevent? And did you diagnose in time any complication? Say, for example, injury to ureter, injury to bladder, injury to any other structure. So did you diagnose in time? And very important questions come. Did you manage way in which any prudent doctor would have managed? If you can answer all these questions, then you could be out of problem. So keeping in mind all these questions, let us discuss how we can avoid litigation. So three major issues, and it is expected by court also. Practice foreseeability or anticipation, good communication, valid consent, and proper documentation, and you will be simply sailed through. So as far as anticipation is concerned, foreseeability is concerned, let us discuss how we should anticipate or how should we discuss with the patient as far as our treatment plan related to endometriosis is concerned. Anybody can take.
So with respect to endometriosis,
yes,
any complication we can say is foreseeable, meaning anything can happen. So the common complications which could happen, we'll have to enumerate and explain as it relates to the proposed procedure. And we should also say what kind of care we are taking to avoid that complication, although it's a common one.
Not only we should anticipate, but we should be mentally prepared to deal with accordingly. Say, for example, just we saw that case of endometriotic nodule on sigmoid colon. So whenever you are dealing this type of situation, would you like to inform your professional colleague, surgeon, laparoscopic surgeon, if at all it is needed, then he or she should be available to assist you. So that is anticipation.
Yes, sir. I think we will inform the surgeon or the urologist or the rectovaginal surgeon, and we could have probably taken a consent for colostomy before having operated, having known that it is a deep infiltrating endometriosis on the sigmoid colon. So we could have probably taken a consent for colostomy and explained to her what colostomy is and what procedure it would and how long it would take for reversal of colostomy, what is the success rate, the back treatment and things like that. So all those things should have been discussed with her. And with that, if she's going in for any complication, maybe the need for blood transfusion, the need for ICU care, and the need for her mobility, etc., also should have been told and taken a consent.
Yeah, can I speak, sir?
Yes.
Sir, very valid points put by everybody. I agree with both Arul and Palani that yes, we have to take everything. The thing is, some standard investigation protocol also should be, put in place, and ultrasound or MRI or whatever is done should be documented well. And all this CECT maybe sometimes becomes necessary to check on bowel involvement. So all this will help us to anticipate the difficulty. And what we do in our practice, sir, is we actually put the patient across to another consultant, maybe oncosurgeon or more commonly laparoscopic surgeon, along with, because if we approach laparoscopically, a surgeon who is well versed with management of adhesive disease in the pelvis, especially endometriosis, before the surgery. That means the patient should have seen the other consultant as an outpatient, should have consulted the other surgeon as an outpatient. So that gives them a connect that another surgeon is involved. It is because on the table, the patient will be under anesthesia and the family will not be familiar with the other consultant. But I think we need to bring in the team before the patient is in the OT. So in that way, it helps us. Yeah.
Shobha, very, very valid point. This brings us to this term called ghost surgeon, where the family does not know who's coming, doing any procedure, any add-on procedure, and who's going out. And the name is not revealed even in the billing.
Yeah, and in the court of law, definitely, then only we are involved.
It's important.
We will discuss little later on. So if we anticipate any our professional colleague to be involved, surgeon or urologist, then they should be informed that if at all it is required, you should come to our assistance. But if we anticipate, then our main role is proper counseling with patient and relative of the patient. It is very much important, because more is the time you spend with the patient in consulting room, it is very obvious. Less is the possibility you needing to spend time with that patient or relative in courtroom. So it is very important. And
also bowel preparation in deep infiltrating.
We are coming. Communication is the key to avoid litigation, and it is very obvious. We might have the best medicine in the world, but it won't be successful if patient doesn't understand it. And that is why at the time of our counseling, usually we start like this: what is the complaint in our consulting room? And there are so many questions on part of patient. Why did it happen? How it can be avoided? Will it happen again? Could it have been avoided? So there are so many questions on part of patient. So how will you counsel this patient, keeping in mind not to end up into any kind of litigation as far as treatment of endometriosis is concerned? Yes, anybody can take.
Yeah, I think
counseling.
So I think patients and families like it when we talk about the disease per se and the difficulties which we are going to anticipate during the surgery. So they develop a lot of connect. If we are able to tell them that endometriosis is a disease where adhesions are very, very vascular and firm, and if we have to dissect, then we have to be ready to tackle the parallel organ damage. So we have to tell them the nature of the disease. We have to also tell them that the first surgery, or even for a recurrent surgery, what is that called? Complete excision is very important for cure. And as far as possible, we will be trying to remove the disease, and that may require us to go close to other organs. So I think we need to explain to them how difficult the disease in itself is.
And we are supposed to have alternative modalities of treatment. We have to offer all the
surgery in endometriosis today is actually the last resort.
So
medical management should be well documented. Well documented.
So we should explain that also. One more.
Yes, sir.
As far as morbidity is concerned, if at all, then we have to explain probable expense, probable, because it may extend also. Mortality in very few cases, probable prognosis of the disease after treatment, probable complications. We should explain that also. Possibility of blood transfusion in few of the cases, risk involved. Just we may discuss the case related to sigmoid colon, this endometriosis nearby sigmoid colon. So in this type of whichever risk is involved, we should explain that also. But whatever we explain, it should be in a very simple language which patient can understand. No much medical jargon. And one very important area, would you like to give guarantee of result as far as your surgical or medical part of treatment is concerned about endometriosis?
We need to be guarded, sir. We need to be guarded, not go give a rosy picture.
Yes. So no rosy picture about result, but no tall claim about picture, because many times we consider our result of our treatment of endometriosis like Aishwarya Rai, but it may turn like this at any time. So no tall claim, no rosy picture, because in eye of law, when you claim to be master, then you are supposed to be master. So proper communication is very much needed. And once you take signature on consent paper, it becomes a documentation of your communication. Because in this famous case of C. Jaipal Reddy versus Padmini Velluri, National Commission has very specifically mentioned that consent is not mere piece of paper where patient or patient relative has to sign, but it is a very important document. Whatever you have counsel, it should be entered. Every point should be entered in consent paper, and then after patient should sign. And once patient signs the document, it becomes a documentation of your communication. So many times this question also comes. And this famous case of Samira Kohli versus Prabha Manchanda, which was decided in Supreme Court long back in 2008. And in this particular case, at the time of deciding this case, concept of consent in India was discussed and decided. And what is the valid consent in Indian context was decided, and Supreme Court came out with some guideline as far as consent is concerned. So we should keep in mind, and first point was capacity or competence. Who can give consent? Because many times mother-in-law signs the document, husband signs the document. So is it correct?
Anybody who is above 18 years in proper mental health, I think the patient has to be informed, and she has to be the first person to give consent.
Yes. So if patient is major and if patient is mentally sound, only and only patient can give consent on her behalf. Nobody else can give consent on her behalf when she is adult and when she is mentally sound. But if she is minor or if she is mentally challenged, then consent of guardian is very much required. But if it is an emergency, then no consent is required. But again, burden of proof is on your shoulder to prove that it was dial emergency, and to save life of patient, whatever you did, it was very much necessary in given time. So this is very much important. So, and whenever you offer all this record in court of law, it becomes a communication of your documentation. So naturally, record is always at your rescue. So let us discuss something about record. How will you maintain this record, or which kind of record would you like to preserve as far as treatment related to endometriosis is concerned? Anybody can take.
So we keep the records in the medical records department for 5 years. If it is going to be.
I am not asking for a time period, but which kind of records means OPD case paper, indoor case paper, investigation, if you have done that way, I am asking.
Sir, actually, the records are for the OP patients are kept as a carbon copy of what is being done. That is one, and the inpatient records are kept on the as the MRD files, and so we would actually maintain the OP and the IP files. And few hospitals, now that it's computerized, and especially after the COVID, I think when we put the hospital UHID number, I think we will get all the investigations, whatever has been done date-wise, which is very easy, but then not possible in all the hospitals, I should agree.
For us, OPD has become e-files. OPD records in the hospital have become all e-files, and with the patient number, all investigations are stored there. Patient carries all the hard copies. Then, as far as inpatient is concerned, inpatient files are generated, both hard and soft. Discharge summary is also maintained in hard and soft. Both are maintained.
So keep them up to date. What was done? Nothing was neglected. And as far as our treatment plan is given treatment fully met with standard demanded by law and ethics and as per our standard medical norms. We should treat any patient as per our standard medical norms or medical protocols. And in court of law, court always considers standard textbook. So whatever given in standard textbook, if you have adhered to that treatment plan, it is considered in court. Then one more area is considered in court: practice prevailing in nearby medical college hospital. So in the same situation, how the medical college hospital would have treated this patient. So it is also considered in court of law in this type of situation. So given treatment should be met standard demanded by law, ethics, and our standard medical norms, and it should be easily acceptable whenever offered in the court. So as far as records, principle of records are concerned, so this should be kept in mind. This is one more very important area, and that is important bill about not only purchasing of oxygen cylinder or ventilator also, but refilling of oxygen cylinder is also one good document as far as record is concerned, because in this famous case which happened in state of Gujarat only, and case was decided in National Commission, a patient has a tooth extraction, and after that he developed Ludwig's angina. Surgery was offered, but on table patient suffered a sudden cardiac arrest. Patient was obese, and allegation on part of relative of the patient was that there was no oxygen cylinder filled. So oxygen cylinder were empty when he suffered a heart problem. And in this particular case, we could produce a bill of refilling of oxygen cylinder just 1 day prior. And it was considered as a good document in our favor, and we won the case in this particular case. As far as facility is concerned, when you are dealing with a case of endometriosis, particularly surgical part, then you should have all the facility. Person should be experienced, and prior consent is very much must. So there is always a way. So how to prevent? Final word from all the panelists one by one. Yes, Palani.
Sir, I think I'll be more bothered about it in a case of endometriosis, proper documentation of what we speak to the patient, the methods possible for treatment, and then of course the complications. I will be the documenting that would be the first way, because it's a chronic disease.
Yes, Shobha.
I have a suggestion that
Yes.
particularly in complex endometriosis surgeries, the surgeon himself or herself should put down the operative notes, and the same should be reflected in the discharge summary also. So
Yes.
that when they come back to us or go to the court with the complaint, these are going to be produced, and we have
You have opened one more area for discussion.
clarity.
If at all during surgery any complications happen, would you like to enter in your surgical note, and would you like to mention in discharge card?
Sir, I would say yes, definitely. It needs
Definitely
to be
yes.
mentioned.
Definitely yes, definitely yes.
Yes.
Say for example, it is injury to urinary bladder.
No
Yes.
problem, sir.
And
I
you,
will mention it.
then you are competent enough. You have sutured it, and everything is fine. And you think now everything is fine. No need to mention in surgical note, and
Not at all. Not at all.
not to discuss with the patient or patient party.
Not at all.
So
No
many
sir, no sir.
No, sir.
So
No.
post-operative counseling is also very much important.
Yes,
If
yes.
any complications occur.
Yes, yes.
Because
Yes,
if at all in this situation, you will naturally go for catheterization for longer period. Then how will you justify? If you have not mentioned or if you have not explained to the patient or patient party,
Yeah.
then
Correct.
because patient will say, because in this type of surgery, usually next day morning catheter is removed. Why you have kept a catheter for such a longer period? So in this type of situation, not to end up into very tricky situation, it is always better to mention in surgical our operative note and in the discharge card also. And we should discuss everything with patient and patient party with all its
Everything, sir.
further treatment plan also.
Honesty and transparency, sir.
Yes,
Important.
exactly.
Yes,
It
sir.
shows-
Yeah,
shows our
absolutely,
transparency.
absolutely.
Yes, one more panelist for final word.
Yes,
Sir,
absolutely.
one more
Yes, sir.
thing I will tell, sir. Always try to maintain the video recordings of all the laparoscopic procedures you do it.
So you open one more area for discussion. Actually, how much time we have, Ramani Devi?
Yeah, it is. Maybe you can take another 5 minutes.
Okay, no issue. So let us discuss very quickly as far as recording is concerned. So if at all you are going to record surgery, say for example, you are dealing with a endoscopic surgery for endometriosis, would you like to have some special mention or consent at the time of taking consent?
Yes.
Yeah. Yes, sir. Yes, sir.
Any photography, videography,
whenever
yes.
you are going to record, you will have to go for consent. And if you are allowing any attendee to attend operation in operation theater, then also you will have to go for consent. And one more area, if you are recorded with consent, but you cannot display to workshop or conferences or webinar without consent of patient. So if at all you are going to display it in future, then also consent for that also we should take at the time of taking consent before surgery. And one more area, in this type of situation, whenever you are displaying this surgery, personal identity of patient should not be revealed.
Should not be revealed. The name should not come. Name and registration number. Yeah, nothing should come.
We should keep
Sir,
in mind.
yeah.
Yes.
Sir, another thing, one more thing is that if the patient desires a copy of the video, we should be ready to share it.
Yes.
Yeah.
And
And
like
that is
any
also
other record.
yeah.
We not only we should give, but we have to give.
We have to give.
Yes.
So, sir, I would also like to say that counseling, consent, everything is very, very important. I would like to add that when complications happen in the OT, then I think the anesthetist also should be told that this and this has happened and what we have done to correct it.
Yes.
So that later on everybody has the same story to tell. It should not happen that, they say something else and we say something else. And if ICU management is required immediate post-op, that also should be told to the patient. So there is a routine protocol for us that as we come out of the OT, when we are going out of the OT, we first speak to the attendants and then we go for any surgery, even for a cesarean. So in such cases, we talk to them, we tell them what all happened. The bad things we'll tell them first, what all went wrong, and then we'll tell them what all went well.
So
and then we'll tell them what
prior
to
surgery,
expect.
we should go with three consent. One consent for anesthesia, one consent for surgery, and if at all we have planned to go for any blood or blood product transfusion, for consent for blood transfusion also. But consent should be procedure or operation specific, and consent can be given to particular person. Doctor so and so will operate that way. Or if you are operating in unit, then you will have to mention the unit headed by Dr. so and so. So it is very important. And not to confuse in this type of situation, because many times patient has given a consent, and we have to, during surgery, we have to extend the scope of consent given by the patient. And in this type of situation, if consent is not given specifically, then what to do and how to do, whether we can approach or not, it is very difficult. So you have to simply visit FOGSI website, and on FOGSI website, FOGSI uniform consent is available with 3 medical legal experts, Dr. Dilip Palke from Pune, Dr. Nikhil Datar from Mumbai, and myself, Dr. MC Patel from Ahmedabad. We have prepared almost 30 different consent. Say, for example, for cesarean section, for hysterectomy, endoscopy, vaginal, abdominal, HSG, medical termination of pregnancy, medical, surgical. So different 30 consents are there. But I would like to mention, we have prepared those consent taking a base of famous case of Samira Kohli versus Prabha Manchanda. And we have prepared those consent in 2 parts. Part 1 is information. And in that part, we have 8 subheading: name of procedure, meaning of procedure, indication of procedure, how this procedure will work, consequences of refusal, probable complications. So this is information part. And very important part is part 2, that is undertaking on part of patient or patient party. So in that undertaking, we have mentioned one line: if any unanticipated things happens and doctor has to proceed, scope of consent given by me, he or she may discuss with Mr. or Mrs. So-and-so who is waiting outside operation theater, and if she give consent, it will be considered as a consent given by me. This type of line we have mentioned. And one more line we have mentioned: if there is unanticipated or unexpected complications happens, and if it is necessary to extend scope of my consent given, I give my authority to my treating doctor to deal with accordingly. So in consent form, we have mentioned all those lines. So if patient has given consent in that sense also, then in this type of situation, you are saved to proceed further accordingly. Yes. Any panelists who have remained to have their final comments?
I think everything is covered. I think it's very important to be honest to the patient.
Yes.
Discuss all options before even considering surgery, because if you talk about complications, they may choose not to undergo surgery at all. So, and we have to always tell them that it's a teamwork. And as you suggested, sir, it is a disease where you can't predict the extent of the disease before looking inside. So it's always good to explain all the complications ahead, and if required, additional procedures will be undertaken. Sure. And good debriefing after the surgery, as you suggested, so that what we have done, whom we have involved, and documenting everything. And follow up, as you mentioned, I think that summarizes the whole thing.
Yes. So I think everything is fine. But this is a common sentence from William Osler: medicine is a science of uncertainty and art of probability. And this is also very nicely said by Vygotsky: the problem with world is that the intelligent people are full of doubts, while the stupid ones are full of confidence. And this gentleman has so many staircases, but he doesn't know how to use them. So it doesn't matter how many resources you have. If you do not know how to use them, they will never be enough. So have some basic legal knowledge. Always obtain medical legal advice whenever you are in doubt. Satya pareshan ho sakta hai, lekin parajit nahi. A small slip can make a big trouble. So an ounce of prevention is worth more than a ton of cure, rightly said in Panch Tantra. So all the best. God bless you. Have a litigation-free medical practice. With regards, salute to all the organizers. And thank you for inviting us to moderate this panel. And a big round of applause for all the panelists and experts to make this panel very vibrant and very informative. So thank you very much. If at all any question, please do not assume, please ask if time and organizers permit. Thank you very much.
Thank you, sir. Thank you for
Thank you
making
so
us
much,
part
sir.
of
Thank
this
you so
panel.
much for the brilliant panel. I think if we have
Thank
to
you.
keep this
Thank you, sir.
education free, we can't practice.
No, not like this.
Thank you, Dr. MC Patel, sir. It was
That's
indeed
4
a
hours
very
free.
informative and I can say very interesting. And as usual, you were superb. And all the panelists, they have done a great job. And an expert, Dr. Parag Biniwale, I think we had a mind-boggling session. Very nice.
Indeed.
And now we move, and
Yes,
now we
Parag.
move on.
Post-test.
Expert at the end, expert comments from Parag.
Yes, Parag.
I've enjoyed the panel to the fullest, and whatever tips Dr. MC Patel gives, they're really, really important for us practitioners, because we should try our effort level best to treat the woman to our fullest ability, and at the same time be safe as far as your own practice is concerned. So this is an important message for all of us, and thank you, Dr. MC Patel and all the panelists for bringing out all these issues to us. So on behalf of ICOG, thank you very much. And thank you, Mama.
During panel, we didn't disturb you as you were busy with some other meeting. So that is why we didn't disturb you.
So I was listening to both the presentations. I have 2 laptops next to each other.
Thank you.
Thank you so much. Now, Komal, you can post the post-test link in the chat box so that our attendees can give post-test. So dear delegates, just see your chat box. The link is posted there and you can start giving your post-test. The time given is 10 minutes.
So thank you, Lakshmitai, also.
Thank you, sir. Start the timer. Yeah. So dear delegates, start your MCQs now.
So now only 1 minute left. So now it's time up. So Lakshmi Madam, will the question be shared on the screen?
No, now you will have to take question answer. Who is taking? Ramni, Asha, you? You will have to show the answers to all the
Yeah. So the tech persons will share the screen with the question and answers.
Yeah. Komal?
Yes, ma'am.
Share that screen with
Okay, ma'am. I have the PPT.
answer. Answer
Yes,
also.
ma'am. Yes, ma'am.
So quickly, Abha, you can go through so that delegate.
Yeah. I'll go through it fast.
Yeah. And then we will wind up and we will
Yeah, sure.
tomorrow
Sure.
at 4 o'clock sharp. Yeah. Komal?
Yeah. She has started sharing the screen.
Start from question 1. Yeah.
Start from question number 1.
Yeah.
So the first question is, which of the following statement is incorrect regarding endometriosis? A, overall prevalence is 3 to 10%.
Don't read all the 4 options, just read the option that is
Correct. So we know that there is no direct relationship between endometriosis and PMI. That is the incorrect statement. Next. What are the risk factors for endometriosis? All except menorrhagia is not a risk factor for endometriosis. Next. Endometriosis is dependent on all, it is estrogen dependent, it is progesterone resistant, and there is increase in VEGF. All the 3 are correct. Next. Which of the following theory does not explain the etiology of endometriosis? It is the Mendelian theory. Other 3 theories, they explain the etiology of endometriosis. Next. The incidence of genetic predisposition is 7-fold increase. Next. The most common symptom associated with endometriosis is dysmenorrhea. Next. Next, please. Which of the following which of the following statement is incorrect? That is, there is no difference in ectopic and eutopic endometrium. Rest other statements are correct. Next. Which of the following is incorrect regarding dysmenorrhea observed in endometriosis? The severity of symptoms, they correlate with severity of endometriosis. This is an incorrect statement. Usually the severity of symptoms, they do not correlate with the severity of endometriosis. Next. Which of the following is least likely the characteristic of ovarian endometrioma? They do not have solid areas. That is the least likely criteria. Next. Which of the following is not the source of estradiol for endometriotic tissue? It does not come from adrenal gland. Next. Ectopic endometriotic tissue shows progesterone resistance and is characterized by high local aromatase activity and low 17-beta HSD activity. Next. Which of the following cannot explain by Sampson's theory? That is endometriosis in premenarcheal girls because they are not menstruating. Next. All of the following can lead to endometriosis in a teenager, an age when endometriosis is rare, except in cases of Turner syndrome. Next. Which of the following is the most common complaint in adolescent endometriosis? It is pain, which is both cyclical and acyclical. Next. The indication of surgery in adolescents indications are all except asymptomatic endometriosis. We do not need to treat them. Next. Risk factor for adolescent endometriosis. All of the above: family history, neonatal uterine bleeding, severe dysmenorrhea, and treatment with OCP for dysmenorrhea. Next. Indications of MRI and endometriosis. Of course, if we suspect malignancy, DIE, or Mullerian anomaly, all of the above. Next. The gold standard for diagnosis of endometriosis is laparoscopy combined with histological examination. Next. Imaging for endometriosis. All the modalities are used: USG, MRI, but not CT. Next. Which of the following is correct regarding endometriosis as per ASHRAE? The useful of 3D sonography to diagnose rectovaginal endometriosis is not well established. Even MRI to diagnose peritoneal endometriosis is not well established, and we should not use immunological biomarkers for diagnosing endometriosis. So all are true. Next. What is the usual delay for endometric diagnosis? It is 7 years. Next. Does laparoscopy have a sensitivity and specificity for endometric diagnosis? 100%? No, it's not 100%, even if biopsies are performed. Next. What is the role of miRNA in endometriosis? It is inhibition of transcription between messenger RNA and protein. Next. What is the sensitivity and specificity of endo test, that is salivary test for endometriosis? It is sensitivity is 96.7% and specificity is 100%. Next. Some have tissues as estrogen agonist in bone, but as estrogen antagonist in breast and uterus. Which of the following is selective estrogen receptor modulator? The answer is vagidoxifene. Next. Vision study done in which group of patients? It is done in adolescent endometriosis patients. Next. Orally active non-peptide GnRH antagonist is used for endometriosis associated pain is elaglox. Next. Which of the following is incorrect regarding Dynogest in endometriosis? It has more adverse effect on metabolic profile. It does not have adverse effect. So the answer will be more adverse effect on metabolic profile. Next. Others are correct. Unilateral endometrioma management in perimenopausal women. We can do either hysterectomy with BSO, unilateral surgery of the lesion with medical management, or even medical management. All of the above are correct. Next. Month for endometriosis awareness. I think it's the next month, that is March. I think with this we come to the end. Thank you so much.
So I think all the questions are based upon the
today's
topic
module.
what we have discussed. Almost everything. Nothing is new.
Nothing is new, and
So
tomorrow
I've
you
attended
all,
properly.
yes, Ramani, they all will have to log in at sharp 4, because from 4 to 4:10 there will be review of first day what we have discussed. 4:10 to 4:20 is pre-test. So do log in at sharp 4 o'clock, because we will be starting at 4. Yes, Ramani.
Yeah. So somebody has asked whether we can get the recording.
That we have not yet discussed.
Decided.
So,
Okay.
yeah.
So then tomorrow the topics you are based on the invitation we have put it. So the following topics will be dealt with, and the questions will be based on that only. So they can just have a brush up of the topics and come back.
Yes. Yes. So very good. So well done, Ramani. Asha, today's co-convener, Abha. So I'm really happy that there are so many messages by delegates that they are appreciating. They have learned a lot. So dear delegates, good night. See you all tomorrow at sharp 4. Komal,
Thank you. Thank you. Thank you, Lakshmi madam,
Yes,
Ramani
ma'am.
madam, Asha madam, for giving me the opportunity. Thank you. Thank you so much.
Thank you.